Good evening, everyone. Good evening. You're all very welcome. We're just letting everybody into our room. We ask you to put your cameras off and your microphones on mute. As we let everybody in, we'll leave our speakers with their cameras on. We're just letting everybody in the room. And on behalf of myself and Seamus, and on behalf of the Irish Society of Medical Oncology and Cancer Trials Ireland, we are delighted to welcome everybody to our virtual ISMO After ASCO updates meeting. This is the third year I think we've done it on this virtual format, but of course this meeting has been running in some format for decades. And it really is a delight to see the strength of presenters we have. We look forward to their interpretations and updates from what was a really interesting meeting this year. Some years are more interesting than others. And actually, I think there was a lot of practice changing updates from this year's ASCO meeting in Chicago. And so we're thrilled to be able to bring a flavour of it home to Ireland to be enjoyed by those of you who couldn't make it to Chicago. A couple of housekeeping measures for tonight. So I ask you to keep your cameras off and your mute button activated. If you would like to ask a question following our speaker's talk, we will have a couple of minutes, and truly 2 minutes only, for questions after each presenter. So please put a question into the chat. We will not be able to get to every question, but myself and Seamus will have a look through and try and highlight ones that might be of most interest to the audience or that we can get through in time to ask our speaker. So any questions to go into the chat box and we'll try and get to them after the speaker's talk. We will be moving along quickly in time this evening, and we're very grateful to our speakers for preparing what we're sure will be some great talks this evening. So I'm going to kick it off, or let Seamus kick off our intros for this evening.
So thanks very much, Michaela, and also just a shout out to Claire Hopkins from Cancer Trials Ireland, who's been hugely involved in the logistics of today's meeting, and Angela and all the CTI staff. So we have a great lineup today. I'd like to echo Michaela's thanks also to our speakers. It's very hard to summarise what Brian Bird describes as a fire hydrant of information, and we've tried to curate things based on feedback of previous meetings as regards. So speakers are limited to 3 presentations for each meeting, for the meeting that they went to in their stream, and also 1 take-home slide of what I would do differently on Monday based on what I learned at ASCO. We've also tried to highlight early career people and our trainees. We have a trainee abroad session as well, and also highlighted at the end some practice changing presentations that have had Irish leadership presenting at ASCO with concurrent New England Journal of Medicine publications, which is really where we would want to be, as Jerry Hanna, the vice lead in Cancer Trials Ireland, says, leading the world from Ireland. So our first speaker is Catherine Weadick, who is also from the Cork Parish and is now in Toronto and has just got married. So the team of 66 here would like to extend our congratulations to you and Dave, Catherine. So and Catherine is working on in the sarcoma field in Toronto, and is going to give a sarcoma update today, and also from the perspective of an early career investigator and an exemplar of one of our wonderful trainees from the ISMO program here. Welcome, Catherine.
Thanks, Prof. I'm just going to share my slides. Oh, sorry. Can everybody see them? So Catherine Weadick is my name, and as Prof said, I'm a clinical fellow here in Princess Margaret Cancer Centre, and I'm going to present an update on sarcoma from ASCO. I know that there's a broad range of different people from different backgrounds. So sarcoma is one of the rarer cancers, and the title itself represents over 80 different subtypes or different types of sarcoma. So my presentation is possibly a little different to some of the others that you'll see, as other tumour groups are able to have bigger clinical trials with much larger numbers. And then sarcoma is also a difficult cancer to treat. So we judge success differently to some other tumour types. So the first thing that I'm going to speak about is a phase 3 randomized trial called the Maneuver study, which looked at pimicotinib in tenosynovial giant cell tumour. So giant cell tumor is a benign tumor that arises from the synovium or the tendon sheet, but it can cause a lot of pain and swelling and joint dysfunction, which has a large impact on quality of life of patients and can often compromise joint function. It is caused by aberrant CSF1 and CSF-R1 signaling, and pimicotinib blocks that signaling. So this trial, as you can see, was a phase 3 trial that was randomized with placebo and was randomized in a 2:1 fashion for pimicotinib to placebo. And you have to be an adult to enroll in this trial, but it can affect people under the age of 18 also. So they were able to enroll 63 patients to pimicotinib and 31 to placebo. The median age range was 41 and 36, with the majority of patients being female and the majority of patients having a tumour in their knee, which is what we would see every week in clinic. It was also quite spread internationally, with China, Europe and North America involved. You can see from the graph that they had quite good responses to the treatment, and the overall response rate was 54% to pimicotinib versus 3.2% in placebo, with 52.4% of patients having a partial response, which also happened quite early in their treatment regimen, and one person had a complete response. This is quite a well-tolerated drug, although it can cause derangements in LFTs, but overall people tolerate it well. So this has had a large effect on the patient's quality of life, and we also had this study here in Toronto. So next is an off-label study that has a lot of interest to me. So it's off-label use of trastuzumab deruxtecan in desmoplastic small round cell tumours. So desmoplastic small round cell tumours are very aggressive, rare small round blue cell tumours, and many of these patients unfortunately do very badly. It's predominantly a cancer of AYA patients with a male predilection, and they have a pathognomonic EWSR1 WT1 fusion. And this group from Memorial Sloan Kettering found that there was overexpression of HER2 in these sarcomas when compared with other translocation-driven cancers that are seen in AYAs. So first, they looked at 61 samples of patients with desmoplastic small round cell tumours and analysed their samples using RNA sequencing. And then they also performed tumor microarray on 52 of these samples to look at HER2 IHC staining. And they used 3 different ones as shown here, with 4B5 being the most common one that's used in breast cancer and GI cancers. So they determined the overexpression level by reviewing HER2 expression using RNA sequencing in over 340 samples, which represented 23 different histologies, and they found a threshold of 27.42 transcripts per million. And then they looked at the diffuse small round cell tumour at the microarray using IHC, and they found that only 3 of the 52 patients showed as positive using the HER2 microarray that's normally used for breast cancer and GI cancer, being the 4B5. So they then chose an analysis period of 18 months, during which 19 patients initiated on treatment, and they presented on 16, and this treatment was very well tolerated. You can see that there was only 1 female in this group, which is very common. We mainly only see males with this, and the median age was 21, and it was a very heavily pre-treated population, with everyone receiving between 2 to 6 prior lines of treatment, and 50% of patients had received radiation, with the majority being whole abdomen pelvis. So this is just a slide showing the treatment characteristics and responses of those 16 patients. You can see that 3 patients received alternating trastuzumab deruxtecan with chemotherapy, and 9 of the 16 patients had a partial response, and the 3 patients who received the alternating chemo and trastuzumab deruxtecan actually didn't have a partial response. They were in the stable disease group. And also 13 of the 16 patients were found to have overexpression of HER2 by RNA sequencing. So just to highlight 2 cases, this is the first of a young man who had quite severe disease and was an inpatient at the time with a lot of respiratory symptoms. You can see from the slide that he had 2+ positive on HER2 staining, and he had a very good response to the TDXD. He unfortunately had progressive disease after 4 months, and with spinal disease, which needed to be resected, and that interestingly was found to be HER2 negative. And then a second patient who also responded very well to the trastuzumab deruxtecan was actually negative on all of the staining and also on RNA sequencing, but was found to have a very good response to the treatment and was continuing on the treatment at the time of this presentation. So this is a swimmer's plot which describes the experience of the centre, demonstrating a 59% overall response rate in this early and preliminary off-label experience, which I just want to highlight isn't a clinical trial, but does show the good activity of trastuzumab deruxtecan in this ultra-rare sarcoma. And the take-home points were that it does suggest favourable activity of the TDXD, and it has also led to the desmoplastic small round cell tumours being included in a phase 1, phase 2 trial looking at TDXD in other AYA cancers with fusion positive or fusion driven cancers. So that has been added to that trial. It also shows that IHC staining and or RNA sequencing are not sufficient to show as biomarkers for who will respond to TDXD. And it also highlights that drug development in rare and AYA cancers benefit from early and more flexible access to novel agents. So then the last project that I'm going to show you was actually from the centre that I'm in at the moment, and it was about detecting ctDNA using personalised structural variants to forecast recurrence in a localised soft tissue sarcoma. So the standard of care treatment for a soft tissue sarcoma is surgical resection with radiation, with the majority of patients getting neoadjuvant treatment, but some do get adjuvant radiation. And unfortunately, 50% of people treated with this plan will then go on to develop disease recurrence. The benefit of adjuvant chemotherapy in this population remains controversial. The centre that I'm in at the moment does not give adjuvant chemotherapy to this group, whereas in some centres in Europe, they would give chemotherapy. So the question was raised whether they can use ctDNA to identify patients with residual disease after surgery from a ctDNA perspective that could benefit from adjuvant chemotherapy. So this is the study schema of when you can see that they take the plasma samples before and after radiation, before and after surgery, and then into the surveillance period. So this is the graph showing all of the patients with their diseases. The black dots show when there's positive ctDNA. So you can see the 22 patients had their ctDNA collected within this window. 4 patients had detectable ctDNA during this minimal residual disease window, which was 8 weeks after their surgery. And all 4 of those patients went on to develop recurrent disease. 3 patients went on to develop recurrent disease that was radiologically evident, and they all had signs of positive ctDNA before they developed radiological disease. And interestingly, there was also another 4 patients that had positive ctDNA that have never developed recurrent disease to this date, and they all interestingly had dedifferentiated liposarcoma. So the key points from this was that detection of ctDNA using this tumour-informed assay of structural variants is feasible and highly sensitive in resected soft tissue sarcoma. That positive ctDNA within that MRD window was associated with subsequent and early radiological relapse, and that MRD positivity should be used or should be evaluated as a predictive biomarker to try and select patients who may benefit from adjuvant chemotherapy in this setting. So I was asked to find what would I do differently in this clinic. After this, I do think that the trastuzumab deruxtecan trial especially highlights that it's important that all of these patients with ultra-rare sarcoma are registered onto the international database, which they are currently starting up, to allow planning and participation in clinical trials for these patients with the rare tumours. And it also allows us with information to go to the drug companies to advocate for our patients, to try and get access to these drugs that obviously do have efficacy in these rarer tumours and can try and improve our tumour outcomes, or patient outcomes, sorry. And that's just a picture from this weekend. So thanks for the opportunity.
Thank you, Catherine. Always really interesting to hear from somebody different about interesting tumour types and to hear activity about drugs that are quite different to some of us, and some like trastuzumab deruxtecan, which we're seeing activity of in lots of different places. So just a reminder that we do have a couple of minutes for questions after each speaker. If you would like to pose a question, please type it into the chat box, and myself and Seamus will look at that and try and bring it to our audience. And reminder that ctDNA is a type of liquid biopsy, and there is a dedicated liquid biopsy talk coming up in about half an hour from Dr. Jemma Buchalter, for those that want to listen on later to that. I was interested, Catherine, the first study that you mentioned, be it small for a rare tumour type, had a randomisation between an active or potentially active drug and also placebo. And we don't often use placebo-controlled trials in oncology. Could you maybe comment on why that's an appropriate study design for that patient population?
Yeah, so it's a benign tumor, so it's not a known cancer, and it can be quite slow growing. But also there is no other proven gold standard treatment for for giant cell tumors at present. We do sometimes use xalendronic acid or denosumab, but these patients would have already have received that, so there was no other options in treatment for these patients, so that's why they use placebo.
Thank you. Great. We're going to move on to our gastrointestinal or GI updates, and Dr. Emily Harrold from St. James's is going to give us that update talk. Fire ahead, Emily. Thank you.
Can you all see my slides, hopefully? Not yet?
Yes.
Yeah. So thank you for the invitation to talk. As Michaela mentioned, I am a GI oncologist in St. James's, and I'm going to talk about three of what I think are potentially practice-changing abstracts that were presented in this space at ASCO 2025. So, sorry. Here we go. So there are my disclosures. So I'm going to talk about the Breakwater study, which looked at the first-line treatment of BRAF V600E mutation-positive metastatic colorectal cancer. The Atomic trial, which looked at the combination of adjuvant FOLFOX or standard 5-FU-based doublet treatment and atezolizumab, which is an immunotherapy drug for stage 3 deficient MMR colorectal cancers. And then I'm also going to talk about the Challenge study, which looked at an adjuvant structured exercise program for stage 3 resected colon cancer patients. So the Breakwater study schema is laid out here, and I think it's important to put this into context in that BRAF mutated colorectal cancer, when it is metastatic, has quite a poor prognosis when we compare it to BRAF wild type tumors. And what's reflected here in the 3 different arms of this study is what we would consider standard of care, which is typically a 5-FU-based doublet. Sometimes a triplet is considered. The EC here stands for encorafenib, which is BRAF targeting drug, and the C starts for cetuximab, which is an EGFR inhibitor. And then the central arm here is a combination of all 4 drugs, which is sort of subsequently referred to as the experimental arm. And what was presented at June of 2025 at ASCO was essentially an expanded update from data that had been first presented in January of 2025. What's really important is that at the time of this data presentation, with data cut off in January of 2025 from patients who'd been recruited since November of 2021, in the experimental arm, which is represented here in the middle column, more patients were still receiving treatment at the time of data cutoff than in either of the 2 arms. Standard of care here representing the 5-FU-based doublet, and the EC arm here being encorafenib and cetuximab. But it is important to note that progressive disease was seen in both arms, both the experimental arm and in the standard of care arm. The other thing to highlight here is that a significant proportion of patients, close to 50%, had more than 3 organ involvement, and about 60% across all arms had liver metastatic disease, which is important when we think about a targeted strategy, because there is a suggestion that those patients with a heavy burden of liver disease may actually develop resistance more quickly. So cutting to the sort of the money shot, the progression-free survival here represented really demonstrates how significant and clinically meaningful this arm or this combination is for patients with this type of colon cancer, with a near doubling of the median progression-free survival when we compare the combination to standard of care or just to the targeted treatment with cetuximab. And then if we look at overall survival, this slide is truly unprecedented in metastatic BRAF V600E mutated colon cancer, with a median overall survival of double what we would expect in the standard of care arm. And the standard of care arm here does reflect really what we sometimes and often see in the real world, but a median overall survival of 30.3 months with a significant proportion of patients still on treatment is really clinically meaningful for patients, and really I think was quite unexpected in this patient cohort, given the difficulties that we have treating them, and often with their relative refractoriness to standard of care chemotherapy. This does come at the expense of increased toxicities, with a higher rate of grade 3 and 4 toxicities seen in the combination arm. But what's interesting and sort of contrasts against that is that the duration of treatment in terms of median weeks on treatment was actually longer in the combination arm despite a higher rate of toxicities. And if you look at those toxicities, they're not dissimilar from a GI perspective when you look at standard of care versus the experimental arm, but we do see arthralgias, rash, asthenias, and more pyrexias in the combination arm, probably driven by the BRAF directed therapy. But again, just going back to this idea, the median overall survival here of 30.3 months in this combination group really does exist as, I think, the new standard of care, although it's not yet part of the guidelines. And just to put it into context, this is what the treatment landscape looked like before June of 2025. When we looked at BRAF V600E tumors based on sidedness, we might consider a doublet versus a triplet. And then in the second line setting, on the basis of the Beacon study, we were using the encorafenib and cetuximab in the second line setting. But the median overall survival, if you compare doublet to standard of care treatment, was only about 8.4 months when these drugs were used in the second line setting. And I think that's important when we think about this biomarker directed therapy in a very difficult to treat patient cohort. The second study was the ATOMIC study. So this is in a different biomarker defined cohort. This is deficient MMR colon cancers that were fully resected and stage 3. And what these patients were randomized to would have been standard of care at the time that this study opened in 2017, which was 6 months of 5-FU based doublet therapy with 6 months of oxaliplatin. And the experimental arm combined standard of care treatment with atezolizumab for 6 months, and then a further 6 months of atezolizumab after the chemotherapy had finished. A large proportion of patients were randomized into this trial, but it was difficult to recruit to this trial as it only closed out, I think, in 2024, having opened in 2017 as an international multi-site study. But it does show a 10% difference between the experimental arm and standard of care FOLFOX, which again was given for 6 months, although the groups were stratified by high or low risk stage 3 status. And if you look at the forest plot, you do see that there's an advantage to this combination really across most subgroups, regardless of T stage and N stage, and regardless of high or low risk. But if you look at this low risk group represented here in the last line of the table, it is approximating not being as significant for this group. This is important with regard to treatment, that these patients were getting 6 months of oxaliplatin. As we know, the rate of chemotherapy-induced peripheral neuropathy is higher when you get 6 months of oxaliplatin. And here in both arms, we saw about a 20% grade 3 to 4 peripheral neuropathy, which can be long-term. And it's important also that there were 6 deaths in the atezolizumab arm versus 2 in the standard of care arm, in a patient population that we would like to think we're giving sort of definitive and potentially curative treatment to. There wasn't a significant difference with regard to immune-related toxicities, which we would expect. But I do think it's important to put this into context, because when this study opened in 2017, we really hadn't had a lot of data since the approval of adjuvant 5-FU and adjuvant 5-FU oxaliplatin. And what we do know is that 5-FU based therapy, a proportion of which was given to patients with deficient MMR tumors in the original adjuvant 5-FU studies, was actually detrimental. And we now also have the IDEA study, which suggests that for lower risk stage 3 tumors, 3 months of adjuvant chemotherapy may be sufficient without the same cost with regard to peripheral neuropathy. When ATOMIC read out in 2025, we'd already had 2 potentially practice-changing studies in early stage deficient MMR tumors, one being the NICHE 2 study, where 95% of patients on this study had a near complete response pathologically after only 2 cycles of immunotherapy prior to surgery. And then more recently this year, we had the publication of the MSK cohort, which expanded both rectal and other subtypes of tumors that were deficient MMR and proposes non-operative management of these tumors. And we also know from the melanoma space that giving immunotherapy with the tumor in situ induces a greater response. So intuitively, I think there is globally going to be a shift towards neoadjuvant immunotherapy in this setting rather than adjuvant immunotherapy, although this is definitely clinically meaningful with a 10% difference between the experimental arm and standard of care. And then the final study I wanted to highlight, which I think is really fantastic, because we've seen a lot of retrospective data over the years suggesting that there's a benefit to exercise for patients who are recovering from cancer surgery and treatment. But this was a huge effort that recruited 889 patients over 7.9 years and randomized them to a structured exercise program versus just the standard health education materials. What's really important is that this was supported by physical activity consultants, and the target was to increase exercise by 10 MET per hour per week above what a patient's baseline would have been. And to put this into context, an hour of brisk walking is 4 MET hours. And this is what the intervention looked like. And for anybody who's had their surgery and recovered from chemotherapy, this is quite intensive, with the same level of support required really from these physical exercise consultants, almost as would be required from oncology and supportive services when patients are going through their chemo. But what's really meaningful is that there was a significant difference in disease-free survival, such that for every 16 people, exercise appeared to prevent one person from a recurrent or a new cancer. And furthermore, there was a difference with regard to overall survival, so that for every 14 people, exercise prevented one person from dying. And as a lot of the commentary after ASCO mentioned, if this was a drug, I think this would be worth quite a lot of money, but it's obviously hard to implement in real world time. But it certainly, I think, challenges us all to be much more prescriptive about what we should be telling our patients. So in terms of what I'd like to do differently in my clinic, targeting BRAF V600E metastatic colorectal cancer with encorafenib, cetuximab, and FOLFOX is already part of the American NCCN guidelines. But in Europe, the living guidelines for metastatic colorectal cancer were last updated in September of 2024, which actually predates the presentation of the breakwater data in January of 2025 and June of 2025. And I think that this is really important that we look at this for this very important group that historically have had poor outcomes to standard chemotherapy. With regard to my adjuvant stage 3 deficient MMR colon cancers, again, the recommendation for atezolizumab is already integrated into the NCCN guidelines in America. But I think my preference, and lots of people's preference, would actually be to see the integration of neoadjuvant immunotherapy for locally unresectable or clinically bulky T4 and node positive disease, given what we've seen in the melanoma space regarding the significant benefit of neoadjuvant treatment. And finally, this is what the exercise recommendations look like in my hospital for patients that recover from surgery. And what you can see is that I don't think any of our patients are meeting that target of an increase of 10 METs above their baseline. We do reference a lot of the different supportive agencies, but I do think we all need to look at this study as providing a template for what we should be recommending for our patients. And I'm going to leave a little bit of time for questions. Thank you.
Thanks very much, Emily. That was excellent. Can I just ask you, is there any difference between the Lynch syndrome patients and the sporadic mismatch repair patients in these studies, or has that been drilled down on?
So actually in the niche 2 study, there was actually a statistically significant difference in the rate of pathological complete responses in the Lynch associated colon cancers compared to the sporadic. And just this week, there has been some data in the metastatic setting looking at sort of sporadic, where you'd expect BRAF V600E mutations with deficient MMR tumors. And it does seem that they have nice responses, but maybe have a shorter time to first resistance to immunotherapy, which I think a lot of us sort of see in practice. But I do think in the neoadjuvant space, given the sort of significant pathological responses we're seeing with neoadjuvant treatment, whether it's single agent, whether it's combination, I do think increasingly preferences will move in that direction rather than focusing on the adjuvant setting. And I do think the other thing that jumps out about that study, 6 months of adjuvant FOLFOX followed with 12 months of atezolizumab, I think there are very few health services that can really accommodate that level of expense. And I think the neuropathy toxicity is really significant and wouldn't really be standard of care now for lower stage tumors. So I'm not sure that I would prefer that to be funded if I was looking at neoadjuvant versus adjuvant. Okay.
And finally, just in terms of the integration of exercise into our clinics, I mean, that's I mean, the data is very impressive. If it was a drug, we would be
prescribing it. Yeah.
Yeah. So any thoughts about that?
So I think firstly, it gives us confidence to sort of empower patients to take something back with regard to their autonomy, which I think is really nice, because patients are asking us about diet and what they can do. And I do think we now have a template that's what an exercise intervention looks like.
Yes.
You know, whether we can possibly accommodate the capacity in somewhere like Exwell, I think they'll be flooded with referrals. But I think that there are lots of other options that patients can pursue. And I think this data just reinforces that this is as powerful as a lot of the drugs that we're prescribing when patients are asking about what they can do.
And if I can give a shout out for the NEOACT trial, which is a trial for early stage breast cancer receiving neoadjuvant chemo, where the surveys will be going out to Ulster, and the team from Cancer Trials Ireland will be sending out surveys to the various centres about that. And it may be that could be used as a springboard, which would cascade into other tumour types as well. So thank you very much. Fascinating talk. And Very much appreciated. Our next speaker is Jane Sue from the MAT, who's going to give us a lung cancer update. Welcome, Jane.
Hi, thank you. Can you see my slide?
Yes, perfectly. Thank you very much.
Okay, great. Hi, thank you, the organizing committee, for inviting me to speak today. I'm going to give you the update on lung cancer. These are my disclosure. So these are the outline of my talk today. I'm going to talk on, 3 studies, 1 neoadjuvant EGFR mutant lung cancer trial, and 2 actually small cell lung cancer trial. And of course, stay tuned to Checkmate 816 that will be presented by Professor Patrick Forde later. Okay. So dive into the first abstract. Is a neoadjuvant osimertinib with or without chemotherapy versus chemotherapy alone in resected EGFR mutant non-small cell lung cancer. And this is a NeoADORA trial. So currently, the neoadjuvant and perioperative chemoimmunotherapy is actually the preferred treatment in patients with resected non-small cell lung cancer, especially in patients without EGFR or ALK alteration. However, in EGFR mutant non-small cell lung cancer, the major pathological response rate in the neoadjuvant chemotherapy or the chemo-IO are low, measuring about 0 to 8%. This phase 3 NeoADORA study actually explores whether neoadjuvant osimertinib with or without chemotherapy can further improve pathological, surgical, or long-term outcomes in resectable EGFR mutant stage 2 to 3B non-small cell lung cancer. So the NeoADORA is actually a global randomized phase 3 trial with patients with classical resectable EGFR mutant stage 2 to 3B non-small cell lung cancer. Patients are randomized to 1:1:1 with an experimental arm of osimertinib with chemotherapy, or osimertinib alone, or placebo with chemotherapy. The primary endpoint for this trial is major pathological response, which is defined by less than 10% of viable tumor in the primary lung tumor. And the secondary endpoint is the EFS, PCR or pathological complete response, nodal downstaging, and safety. So the baseline characteristics in this trial are well balanced between all 3 arms. And the primary endpoint demonstrated that the major pathological response rate was statistically significant higher in the both osimertinib containing regimen, ranging from 25 to 26% compared to only 2% in the chemotherapy arm. The MPR benefit was associated with the osimertinib containing regimens and consistent throughout all the predefined subgroups. So the secondary endpoints looking at the pathological complete response showed that the complete response ranges from 4 to 9% in the osimertinib containing regimens, and is only 2% in the chemotherapy arm. And over 50% of the patients with baseline N2 disease were downstage at surgery with both osimertinib containing regimen. The interim EFS analysis is actually immature. However, looking at the Kaplan-Meier curve here, we see an early separation between the osimertinib containing regimen compared to the chemotherapy regimen. So in conclusion, neoadjuvant osimertinib with or without chemotherapy has demonstrated statistically significant improvement in the NPR rates versus chemotherapy alone. And the interim EFS trends has favored the osimertinib containing arms. However, longer follow-up will be required. Over 50% of the patients with baseline N2 disease were downstage at surgery with Osi containing arm versus chemotherapy. So therefore, this trial, the authors concluded that the neoadjuvant osimertinib with or without chemotherapy should be considered as the treatment for patients with resectable EGFR mutant non-small cell lung cancer for whom neoadjuvant therapy is recommended. So the second abstract that I would like to discuss is this maintenance treatment with lurbinectedin with atezolizumab as the in patients with extensive stage small cell lung cancer, and this is the phase 3 Forde trial. So we know that the standard of care for patients with extensive stage small cell lung cancer is first-line platinum-based chemotherapy with immunotherapy, as the trial has demonstrated the efficacy and improvement in overall survival. However, patient eventually will experience disease progression with limited survival. Lurbinectedin, unfortunately, is not reimbursed or available in Ireland yet. However, this is an alkylating agent that is approved in the US and other countries for patients with metastatic small cell lung cancer who experience disease progression on or after baseline chemotherapy. So the preclinical studies have shown that the combination of lurbinectedin with immunotherapy has achieved higher rates of tumor regression and induced long-term T-cell memory. Therefore, this trial actually is investigating the efficacy and safety of lurbinectedin with atezolizumab as a maintenance treatment in extensive stage small cell lung cancer patients who had not progressed on the induction phase of the chemotherapy with atezolizumab. This study design showed that the patient were required to undergo 4 cycles of platinum-based chemotherapy with atezolizumab, and in patients who had not progressed on the induction phase will then go on the second screening on the maintenance phase, and this is a randomization of 1-to-1 with lurbinectedin with atezolizumab compared to the standard of care now, which is the maintenance atezolizumab. The primary endpoint is the independent review facility progression-free survival and overall survival. So the baseline characteristic in all phase 3 trials are usually quite well balanced between the 2 arms. And this trial actually demonstrated statistically significant improvement in progression-free survival and overall survival. The median PFS is 5.4 versus 2.1 respectively, and the overall survival was 13.2 versus 10.6 months with a hazard ratio of 0.73 and a p-value of 0.0174 favoring the lurbinectedin and atezolizumab. So in conclusion, Forde demonstrated a statistically significant and clinically meaningful improvement in PFS and OS in the first-line maintenance treatment with lurbinectedin and atezolizumab. However, and the safety profile of this combination was predictable. Of course, there is increased incidence of AEs because lurbinectedin is actually a chemotherapy drug. However, they are low grade and treatment discontinuation rates were low. Therefore, combination of lurbinectedin and atezolizumab has the potential to become the new standard of care for first-line maintenance treatment for extensive stage small cell lung cancer. Lastly, I would like to discuss the third abstract, the phase 3 Delphi 304 study looking at tarlatamab versus chemotherapy as a second-line treatment for small cell lung cancer. So tarlatamab is actually a bispecific T-cell engager that directs cytotoxic T-cell to DLL3 expressing small cell lung cancer. And this has demonstrated durable anti-cancer efficacy in patients that was previously treated for small cell lung cancer. Currently, the survival for second-line chemotherapy ranges with a median overall survival of 7 to 9 months, and they are modest and also associated with substantial hematological toxicity. Therefore, this trial is conducted to assess whether tarlatamab could improve the survival for patients with small cell lung cancer whose disease has progressed on or recurred following 1 line of platinum-based chemotherapy. Delphi 304 study is also a randomized control phase 3 trial that with patients who had progressed on first-line platinum-based chemotherapy with or without immunotherapy, and the randomization is 1-to-1 with tarlatamab or chemotherapy. The chemotherapy arm includes topotecan, lurbinectedin, or amrubicin, all depending on the local standard of care, as this is a multinational phase 3 trial. The key point is the primary endpoint is overall survival. So the baseline characteristic is also well balanced between 2 arms, and we noted that DLL3 expression is actually quite high in small cell lung cancer, ranging up to 93 to 95%. The Delphi 304 trial actually met its primary endpoint with tarlatamab demonstrating superior overall survival over chemotherapy with a median overall survival of 13.6 months versus 8.3 months with a hazard ratio of 0.6 with a p-value of less than 0.001. Tarlatamab also improved symptoms of dyspnea and cough after 18 weeks from baseline. And lastly, tarlatamab actually has a more favorable safety profile with lower rates of grade 3 or more TRAEs or TRAEs that leads to dose interruption or dose reduction. Cytokine release syndrome is actually more common in tarlatamab as this is a known safety profile of a T-cell engager. So in conclusion, the phase 3 Delphi 304 study have shown that tarlatamab significantly improved the overall survival, progression-free survival, and reducing the risk of death by 40% compared to chemotherapy. And the benefit extended to those with poor prognostic factors, such as patients with platinum resistance, as well as brain metastasis. Tarlatamab has significantly improved patient-reported outcomes of dyspnea and cough, and as well as have lower rates of high-grade AEs or low rates of AEs that led to treatment discontinuation. CRS or cytokine release syndrome or ICANS, immune effector cell-associated neurotoxicity syndrome, are mostly grade 1 to 2 in severity, and as well as these are all manageable. Therefore, Delphi 304 study affirms that tarlatamab as the new standard of care in patients previously treated small cell lung cancer. So what will I do differently in clinic next week? I want to emphasize the importance of molecular testing, even in early stage non-small cell lung cancer, especially in patients that you're considering for resection. Without any actionable genomic alteration, I would consider neoadjuvant chemoimmunotherapy. And in patients with EGFR mutant, I would consider neoadjuvant osimertinib with or without chemotherapy. However, I think a lot of translational work needs to be done here to know exactly who are the patients who will actually benefit on the neoadjuvant treatment, as we know that the ADORA study in the adjuvant study actually have shown overall survival benefit with adjuvant osimertinib. In the extensive stage small cell lung cancer, I feel that we need to define who will actually benefit from escalation of the maintenance treatment, whether we have a biomarker or is there a certain small cell lung cancer subtype that actually may benefit in this no chemo-free interval. And of course, in patient who has progressed on on platinum-based chemotherapy, I will look for tarlatamab, like if there is an expanded access program that is available or reimbursement. And finally, I like to emphasize that, clinical trial is the way to go to access new treatment that is available for our patients. Therefore, anyone that, is fit for clinical trial should look for clinical trial for the patient. So thank you.
Thank you, Jane. A really clear talk. And yes, a timely reminder that, of course, these new innovations that we're learning about come about thanks to these patients taking part in clinical trials to help us improve the care we're offering today for tomorrow's patients. So that's really helpful. As always, lovely to see advancements in small cell lung cancer, a lung cancer that has struggled, as we know, for many years to improve survival. I just had some small questions about lurbinectedin and in fact tarlatamab as well. I'm thinking of our day wards, and we already are tight in space and time. How are those drugs given? Are they going to take up a lot of time in our day wards?
So tarlatamab, actually, because of the increased risk of cytokine release syndrome, usually patients should be admitted on day 1 and day 8, and they usually occur within the first 2 weeks of the treatment. But subsequently, if, they still can have grade 1, but, it all can be done as an outpatient. And I think, we will need to learn a lot from our hematology colleagues regarding how to manage the cytokine release syndrome or the ICANS. The lurbinectedin, unfortunately, is not reimbursed in Ireland. So, we don't have the access for those medication. And I think, lurbinectedin with atezolizumab is probably in selected patient. However, how are we going to select the patient? I think a lot of translational work will need to be done to know who will actually benefit from the addition of chemotherapy, or actually a patient would actually do well just with single agent atezolizumab maintenance.
Great. Jane, thank you very much. For the sake of time, we're going to keep moving. I'm delighted to introduce Jemma Buchalter, who's going to give our next talk, which is an update on the use of liquid biopsies, which is a really rapidly evolving area. Jemma is one of our specialist registrar trainees, and she's taking time out of her training clinical programme to take part in an MD research in University College Dublin. So I'm delighted she's going to give us this talk today.
Sorry, I was still muted. So I'd just like to thank you for inviting me to speak today, and just checking you can see my slides.
We can.
Great. So a little bit of background information really on ctDNA. So what is this? So ctDNA stands for circulating tumor DNA, and what they are fragments of DNA that is shed into the bloodstream or other bodily fluids by tumor cells. They are detected by sampling this fluid, such as by a blood test, which is a minimally invasive procedure. They're a dynamic biomarker and can be used to detect minimal residual disease or early cancer recurrence prior to visibility on traditional imaging. And its role is emerging as a pivotal modality in cancer care. So ctDNA featured heavily at this year's ASCO, and I strayed a little bit from the brief in my presentation in that I wanted to highlight to you some of the different ways ctDNA is being investigated for utilization into clinical care. And I'm going to do this by presenting the SERENA-6 trial looking at hormone-positive, HER2-negative advanced breast cancer, the DYNAMIC-3 trial, which looks at stage 3 colorectal cancer, and an exploratory trial from the Aegean trial looking at resectable non-small cell lung cancer. So first, the SERENA-6. So this was a phase 3 double-blind ctDNA guided trial designed to develop a strategy to treat and detect emerging ESR1 mutations ahead of disease progression in hormone-positive metastatic breast cancer. A little bit of background: ESR1 mutations occur in less than 5% of hormone-positive, HER2-negative metastatic breast cancer at diagnosis, but they are detected in approximately 40% of patients on progression of disease as they emerge in first-line endocrine therapy. SERENA-6 investigated switching to camizestrant, a next-generation oral SERD, plus CDK4 inhibitor in hormone-positive advanced breast cancer at time of emergence of an ESR1 mutation. This was detected by liquid biopsy and before radiological progression was noted on scan. This was during first-line endocrine therapy, and they hypothesized that this may extend the duration of benefit of first-line therapy. So for enrollment, patients had to be diagnosed with a hormone-positive metastatic breast cancer and received at least 6 months of treatment with a CDK4/6 inhibitor and aromatase inhibitor. DNA testing was carried out every 2 to 3 months until an ESR1 mutation was detected. When this occurred, patients were then randomized onto trial to continue their CDK4/6 inhibitor, but were randomized to either the same aromatase inhibitor or to switch to camizestrant. The primary endpoint of this trial was progression-free survival. So they met this primary endpoint of progression-free survival 1, which was time to first anatomical progression as detected on imaging. This can be seen on the graph, where you can see early and maintained separation of the curves, and camizestrant demonstrated a median progression-free survival benefit of 6.8 months over remaining on standard care. This translated to a 56% reduction in the risk of disease progression or death when camizestrant was started at this time point. In terms of other secondary endpoints, a significant improvement in time to deterioration in quality of life was seen with camizestrant, a 16.6-month improvement. PFS2, time to secondary progression, and overall survival data is still immature. So what does this mean? So firstly, this is potentially a practice-changing study because it validates a molecularly guided early intervention strategy, shifting the paradigm from the traditional watch and wait for anatomical progression. Secondly, it may ultimately impact our approach to monitoring and treating patients with an ESR1 mutation, and it also provides evidence for the clinical utility of ctDNA beyond prognosis. So we need to wait for the rest of the SERENA-6 trial before incorporating into clinical practice, but definitely watch this space. So next I'm going to discuss the DYNAMIC-3 trial. Professor T presented the primary analysis of the ctDNA positive cohort from the randomized DYNAMIC-3 trial in stage 3 colorectal cancer. Recurrence risk is high despite adjuvant chemotherapy in stage 3 colon cancer, and the prognostic utility of postoperative ctDNA has already been established as a prognostic factor. Strong prognostic factor. This analysis explored whether escalating, so intensifying adjuvant chemotherapy, so chemotherapy post surgery, based on ctDNA positivity, improved recurrence-free survival versus standard of care treatment. Patients were enrolled with stage 3 colon cancer who achieved an R0 resection at time of surgery, who then underwent ctDNA analysis. Patients were randomized 1-to-1 to either standard management as per their treating physician, and they were blinded to ctDNA results, or ctDNA informed management. If the patient was ctDNA negative at this time, treatment was de-escalated, and if ctDNA was positive, treatment was escalated. The primary endpoint was 2 years recurrence-free survival, so time to sign or symptom of cancer recurrence, and secondary endpoints included end of treatment ctDNA clearance. So just to note the baseline characteristics, in the ctDNA informed escalation group, there was a higher percentage of patients with higher risk clinical features, such as a higher T stage, N stage, and extratumoral deposits. So the primary endpoint of this trial was not met, as shown on this graph by no divergence of the curves. There was no difference in recurrence-free survival between standard management and ctDNA informed escalation. In relation to the ctDNA value, regardless of the chemotherapy regimen, there was no difference in the rate of ctDNA clearance. So in terms of the secondary endpoints, so end of treatment ctDNA clearance was met. Post-adjuvant chemotherapy saw about 40% of patients remaining ctDNA positive. If at the end of treatment, ctDNA had been cleared, you had an excellent recurrence-free survival rate. However, if ctDNA was persistent, there was a significantly shorter time to relapse. So in conclusion, in stage 3 colon cancer, the risk of recurrence is high despite adjuvant therapy. ctDNA clearance post-treatment means better outcomes, and using ctDNA to escalate or intensify treatment does not improve outcomes. So what's the impact? So although a negative result, it provides crucial guidance on treatment escalation in this cohort of patients. Treatment intensification may not be the answer for these patients, and this is vital for avoiding unnecessary toxicity when you won't be guaranteed benefit. It highlights the need for novel therapies in this group, such as immunotherapies or even targeted therapies, and could there be a ctDNA subgroup that may benefit from treatment escalation? And it reaffirms the prognostic power of ctDNA, and it raises the question that could ctDNA clearance post-treatment be a potential new primary endpoint in our trials? So lastly, I'm going to discuss the exploratory analysis from the phase 3 Aegean trial. This was presented by Professor Reck, looking at the association of post-surgical MRD status, so that's minimal residual disease as detected by ctDNA positivity, with neoadjuvant ctDNA dynamics, genomic mutations, and clinical outcomes in patients with resectable non-small cell lung cancer. So the Aegean trial was presented at ASCO a number of years ago, and it demonstrated that perioperative durvalumab, so immunotherapy before and after surgery, and neoadjuvant chemotherapy, so before surgery, improved outcomes when compared to neoadjuvant chemotherapy alone in patients with resectable non-small cell lung cancer. A prior exploratory analysis of this trial demonstrated that ctDNA clearance during neoadjuvant treatment was associated with improved outcomes. So patients were randomized to receive neoadjuvant chemotherapy with or without immunotherapy, durvalumab, and plasma samples for ctDNA analysis were collected at pre-specified time points, as I've highlighted in this green box. I want to draw your attention to what they defined as the post-surgical landmark, as highlighted in this red box here, which was cycle 1, day 1 of adjuvant therapy, so treatment post-surgery. So 10.1% of patients were ctDNA positive at this post-surgical landmark. So in all, if the patient was MRD negative, so ctDNA negative at the post-surgical landmark, you had a significantly longer disease-free interval compared to the MRD positive patients. And in the MRD positive patients, so ctDNA positive patients, disease-free survival was poor in both the durvalumab and the placebo arms. Of the patients with MRD evaluable disease at post-surgical landmark, 76.5% of MRD positive patients relapsed or died within 1 year of surgery, compared to only 11.9% in the MRD negative arm. They then found that certain gene mutations may mean worse outcomes in MRD positive patients who received durvalumab. Although these numbers were very small and they need confirmation with larger studies, the findings did suggest that in the durvalumab arm, if there were mutations in certain genes, like the KMT2C gene, then there was a greater association with MRD positivity, and that these patients potentially did worse with durvalumab, as shown by this blue line at the bottom of the screen, unlike those without the mutation who benefited from durvalumab, as shown by this dashed line at the top of the screen. So in conclusion, post-surgical MRD status confers a worse prognosis and potentially a lower magnitude of benefit from treatment. And tumor mutations in certain genes may mean higher clinical chance of MRD positivity and potentially worse clinical outcomes, but this requires further investigation. So what is the impact? So firstly, it validates ctDNA as a sensitive prognostic marker in early stage non-small cell lung cancer. It demonstrates how ctDNA can be utilized to guide adjuvant therapy decision-making post-neoadjuvant therapy and to risk stratify patients, which may lead to treatment intensification or alternative therapies. And it shows how ctDNA can be used to develop a more personalized treatment strategy. So what does this mean? So ctDNA will be the way forward. It has a definitive role in improving outcomes for oncological care. However, we do need to take consideration into the clinical value of ctDNA versus the laboratory burden, financial constraints, and ctDNA panel selection. So thank you for the opportunity to discuss how ctDNA utilization has been explored for clinical practice as presented at ASCO 2025.
Thanks very much, Jemma. There's a question in the chat about adjuvant colorectal cancer stage 3 patients willing to pay for ctDNA testing. So do you feel that the data is good enough not to give chemo to ctDNA negative, node positive patients so far? What's your kind of thoughts on that?
So no, I think with what we're seeing at the moment, I think it's too early to be deciding on treatment based on these studies. But I think the dynamic 3 ctDNA negative cohort hopefully will be published soon, and that will give us some further information.
The Eochagáin data is very interesting, isn't it? I mean, it suggests that there's absolutely no benefit at all for adjuvant therapy post in MRD positive, in ctDNA positive patients that tying up their lives with treatment. It doesn't seem to have any impact at all. It's quite dramatic. That data is quite impressive, impressively negative, unfortunately.
Yeah.
So thank you very much, Jemma.
Thank you.
Thank you. Our next speaker is Sonya Chu.
Can I ask a question?
Absolutely, please.
Am I allowed to ask a question? Thanks. Sorry for interrupting. I won't be long. Jemma, I want to go to the design of the first trial. Patients were randomized when they were found to have a positive ctDNA test. So I guess the first thing that says is you're now telling patients, we found tumor in your peripheral blood and we're doing nothing about it. It's a tough call. Secondly, the end point was the evolution of radiographic changes on the X-ray. Isn't that correct? That was the end point you presented.
Yeah.
And these were patients who were having all these tests, these X-rays done, presumably on a 12-weekly or a 10-weekly schedule.
Yeah.
Not the real world where we don't X-ray patients all the time. So what they've really shown is that there's appears to be a delay in radiographic progression, but that's not really the most important clinical endpoint here. And my question, I finally get around to it, is: did the patients who had not received the camizestrant up front when they showed evidence of positive ctDNA, in other words, when they showed radiographic change, did they then get switched over, or sorry, did they then get added in camizestrant to their treatment? In other words, is it a study of camizestrant versus nothing, or camizestrant later?
So there was no crossover in the study.
No crossover.
No crossover.
I think that's a problem. Yeah.
Yeah.
I think that's a problem. I really do, in terms of assessing what actually happens to these patients when you get to things like event-free survival and overall survival. That might be an issue. So I would be very cautious about interpreting this at all for the moment until you had much further follow-up, particularly with the failure to give this drug later on to patients. That's all I have to say.
Yeah, no, I agree. And they raised that as a point with this study, that it's quite difficult to look at a treatment benefit as well as clinical utility of a test like ctDNA testing in one study.
Yep. Thank you. Very good. Very good.
Thanks, John. It's our next speaker is Sonya Chu, and could I just remind people that we will be doing a photograph
of the attendees after Sonia's talk, so we will ask everybody to switch on their cameras so Claire from CTI can do a screen grab of the attendance tonight. Thanks very much. Welcome, Sonya. Thank you.
Thank you. Now just checking, can everyone see my slides?
Yes, they're visible. Thank you.
Okay, thank you. So I'll be talking about the breast updates for the ASCO 2025. These are the 3 abstracts that we're going to be talking about. 1 in the early HER2 positive breast cancer setting, 2 in the metastatic setting, 1 in triple negative, and 1 in HER2 positive disease. So let's get to our first abstract, which is the phase 3 NeoCARP trial. This looks at adjuvant therapy in the early HER2 positive breast cancer setting. Our current standard of care would be a taxane, carboplatin, trastuzumab, and pertuzumab. The trial question is, can we omit carboplatin, have less toxicity, and still get similar outcomes? So this trial randomized patients who were stage 2 or 3 into 2 arms. 1 was the standard of care with dual chemotherapy.
Sorry.
And dual.
Sonia,
Yeah?
your slides aren't advancing. Now we see it. Thank you.
Hold on.
Maybe put it on slideshow, Sonia.
I see. And how is it now?
We're seeing the NeoCARP study design, but we're still seeing your notes format rather than the slideshow format.
Let me try it again. Okay, how is it now? Is it moving?
That's working. Well done.
Yeah. Okay, sure. Okay, so going to the NeoCARP study design. So patients are randomized into patients were randomized into 2 cohorts, 1 with the standard of care, and then the other one was just the taxane and pertuzumab and Herceptin and pertuzumab alone. The primary endpoint was PCR. So what the trial showed was that most of the patients had tumors that were smaller than 5 centimeters. Most of them were stage 2. And since this was a global trial, there were various types of taxanes used, with around more than 40% having nab-paclitaxel, which is not what we commonly use here. The rest was docetaxel and paclitaxel. So the trial showed that the PCR rates in the overall population was similar across both arms, and this was statistically significant. And this was a non-inferiority trial as well. When they broke it down according to the hormone receptor status, both of the PCR rates were also similar in both of the arms. And the results also tallied with what we previously know, that patients with ER negative and PR negative breast cancer in the HER2 positive setting tend to have higher rates of PCR compared to those who are ER positive. These are the trials that gave us our standard of care today, with PCR rates ranging from 56 up to the high 60s. So how does this compare with the NeoCARP trial? Of course, with the caveats of cross-trial comparisons, we see that the overall PCR rate is similar, both in the overall population and also when broken down according to the ER status. So can we omit carboplatin from our standard neoadjuvant current chemotherapy for early HER2 breast cancer? I would say yes. We see similar PCR rates with less side effects. However, there are caveats. For now, I would probably focus on stage 2 patients only, just because in this trial, only 20% of patients had larger tumors and only a quarter had stage 3 disease. And I do think we need further follow-up to see, can we also safely de-escalate treatment in the stage 3 patient cohort. There's insufficient evidence to support nab-paclitaxel as the chemo backbone, and so the treatment should be given alongside weekly paclitaxel or docetaxel, like what we currently do. We now go on to the second abstract, which is the phase 2 OptiTROP Breast 05 trial. This trial looks at first-line therapy in patients with metastatic triple-negative breast cancer who are PD-L1 negative. This is a cohort of unmet need, because our current standard of care in this cohort would be chemotherapy. And we know that chemotherapy has a lower response rate, and the time to disease progression is around 6 months. So the trial question was, if we use an antibody-drug conjugate, sacituzumab tirumotecan, or SAC-TMT for short, would these patients have a better outcome? So this is a phase 2 study, single arm. Everybody got the SAC-TMT, and treatment was until disease progression or toxicity. And the primary endpoint was overall response rate.
Why are there cups all under the thing? Why are those 3 cups there?
Can someone please mute?
Cup and the spoon. Why is all that stuff there?
Can we remind everybody to put themselves on mute who's listening? Thank you.
Okay, so in this trial, we see that the patients mostly had low PD-L1 expression, close to 80%. And this is the cohort that we're really looking at, as these patients will not have been eligible for immunotherapy upfront. So the trial did show a nice overall response rate of almost 70%, which is almost double compared to what we see from conventional chemotherapy. And when we look at progression-free survival, it's also much more improved, with a median progression-free survival of 13.4 months in the overall population. And if you break it down to patients who had low PD-L1, the median PFS was almost the same. So the take-home message is that SAC-TMT does show promising activity in the first-line setting for triple-negative breast cancer. PD-L1 status did not seem to affect outcomes, and so a phase 3 global trial is planned and is something to look out for. We do see much higher response rates and potentially better time to disease progression as well. Finally, in our third abstract, I'm going to talk about the phase 3 Destiny Breast 09 trial. And this trial looks at first-line therapy in metastatic HER2-positive breast cancer. Our current standard of care would be a taxane with trastuzumab and pertuzumab as per the Cleopatra data. And we currently have trastuzumab deruxtecan in the second line, as from the Destiny Breast 03 data previously. So this trial asked the question whether if we bring T-DXd into the first line, would patients have a better outcome? So this trial has 3 arms. One is T-DXd alone, the next is T-DXd plus pertuzumab, and the other arm would be the standard of care. For this talk, I'll be focusing on the T-DXd pertuz and the standard of care arm, as the T-DXd alone arm has not been fully released yet. And our primary endpoints would be PFS. We see that the PFS in this trial shows a clinical and statistically meaningful benefit, with the curves separating early, with a median PFS of 40 months in the treatment arm versus 26 months in the standard of care arm, and a delta of 13.8 months. However, one thing to note that in this trial, it's a global trial, so not all patients would have access to neoadjuvant or adjuvant anti-HER2 therapies. So in this trial, around slightly more than 40% of people had treatment in the early breast cancer setting, but very few of them, less than 10%, had access to pertuzumab or T-DM1, which is not really the cohort of patients that we would see here in the real world setting. And also, because this trial did not allow crossover, patients who managed to get T-DXd in the second line from those who are on the standard of care arm were also lower. And also, it also depended on where they were from and whether they could get access to further anti-HER2 therapy. We know T-DXd does have side effects that we take an interest in, particularly pneumonitis. And so in this trial, the rates were pretty similar with no additional signals. However, there were 2 patients that passed away due to this side effect. And from a cardiotoxicity point of view, there were no additional safety signals as well. There are some questions that arise with this trial. How long do we actually need to give T-DXd in the first line? And our current standard of care is to give induction chemo with anti-HER2 therapy and then switch to an anti-HER2 maintenance until the patient progresses. In this trial, all of the patients stayed on the T-DXd until they progressed. So can we give induction T-DXd and then switch? We don't know yet. The other thing is the optimal sequencing. As already discussed, patients who progress in the standard of care arm only 10% have received second-line T-DXd to date, and close to 30 to 40% of patients who progress have not yet received second-line therapy. So T-DXd and pertuzumab improve the length of time of disease control compared to our current standard of care. It could be a possible new standard of care in the first line, but we do need to be able to select patients who will benefit from this upfront. And also we need more data to inform us on can we safely switch to a maintenance antibody therapy, which is much better tolerated in the long run. So what do I do differently in clinic next week? So from the NeoCup trial, yes, I would consider omitting carboplatin from my stage 2 HER2-positive breast cancer patients who are planned for neoadjuvant therapy. From the OptiTrop trial, we don't have access to this in the metastatic setting yet, and we await phase 3 data. However, we do have access to this in the early setting through a clinical trial, which is now open in St. Vincent's and due to open in Galway soon as well. These are in early breast cancer patients, triple negative, who got their neoadjuvant therapy and have residual disease in their surgical specimen. So please keep this trial in mind, and we are happy to receive referrals. Finally, for the DESTINY-Breast09 trial, we now currently have T-DXd for metastatic HER2-positive breast cancer as second-line therapy, and we would need to wait longer outcomes and to know how best to select patients for the first line. Thank you.
Thank you very much, Sonya. Really clear talk, great selected abstracts. For the sake of time, Seamus and I are going to talk less, and we will only take questions from the chat section. We would like to see your faces. Please turn on your cameras so that we can get a screen grab of as many of you as possible. We're told that the screen may only fit 50 patients, but let's see if we can get as many as possible for a quick screen grab, and then we'll move on with our next speaker. Min Yuen Teo is waiting on standby to give his GU updates. It's a strong showing from Malaysia this evening at the ISMO After ASCO. All right, I'm just seeing 9, but perhaps Claire, you're seeing more on your screen. Are we ready to go for our photo?
I've got the 449. There's still quite a lot of people
Fantastic.
without their cameras on, so maybe we're feeling shy. If anyone is, please do turn
All
the cameras on because it'll look better.
Okay, so we'll say a big 1, 2, 3, smile, you're on camera.
Okay,
Great.
1, 2, 3.
Thank you, everybody. We appreciate it. And now we don't want to see your faces. You can put them all off again. Min, please, we're looking forward to hearing, and we're sorry for the slight change in the agenda. We want to hear your genitourinary updates from ASCO, please.
No problem. Good evening, everyone. Let me set the screen share. Can you see my screen?
Yes, we can.
Yeah, thank you.
Okay. Let me move the, okay. Oops. Right, so thank you for the invite to speak, to provide you updates. So I'll get started. So these are my disclosures very quickly. So, okay, I've taken a flagrant defiance against Professor Higgins' instruction of 3 abstracts. So I smuggled 1 extra additional one. Instance GU cancers technically is 4 different disease types. But really, it has been the fairly lean year in ASCO this year from a GU cancer perspective. Looking through, there's only been 4 phase 3 trials which have the potential to potentially change practice. 4 phase 3 new data, and 2 of which were not quite relevant to medical oncology and were more early stage urologic abstracts, and there's been a lot of kind of phase 2 and updates on other older phase 3. So that's one. So these are the 4 abstracts I'll be covering. So the approach I'll be going is I'll go through the data for each of these abstracts, and then I'll have a summary to the very end with some comments for myself. So the very first one is a phase 3. Actually, let me make this screen small. Yeah. So the very first is a phase 3 amplitude trial testing niraparib, a PARP inhibitor, plus abiraterone in patients with metastatic castration-sensitive prostate cancer with alteration in homologous recombination repair genes. This was a late-breaking abstract. And so, 1 second, this screen is not switching. Right. So a bit of kind of background. So that's PARP inhibition story in prostate cancer, I believe, is quite familiar with many audience at this point. But just to refresh everyone's memory, a lot of the data we have, especially in combination with ARPI, are from a metastatic castration resistant prostate cancer setting. So which is quite different. And there are at least 3 phase 3 trials. I have listed them out here: Propel, TelePro-2, and Magnitude, confirming that at least in patients with metastatic castration-resistant prostate cancer with at least homologous recombination deficiency, the addition of a PARP inhibitor to either abiraterone or enzalutamide, any of the ARPI, have been able to improve at least radiographic progression-free survival and OS in some of these cases. But so there are a few caveats here. So a lot of these studies enroll patients with any of the HR, there's a panel of HR deficiency genes. But when they look at the breakdown, so this is a meta-analysis from researchers within FDA where they have all the individual patient level data. The benefit from the additional PARP inhibition is really from just a few different gene alterations, and mostly driven by alteration in BRCA1 and 2. And also another important clinical point is that if you look back here, these 3 phase 3 trials which have been presented, they are in a castration-resistant phase, which means they are technically second line in the metastatic, at least second line in the metastatic setting. And of all of these, there's very few patients actually receive ARPI in the first line setting. So this is really not in keeping with current modern practice, in which most castration-sensitive prostate cancer would be receiving standard ADT plus an ARPI, especially if they're high-risk metastatic disease. So in a way, these data from previous PARP inhibitor trials are sort of outdated and may not be applicable to our current landscape. So this is really one where this trial comes in. So the study design is a fairly straightforward phase 3 one-to-one randomization, but the key feature is in the key inclusion criteria. So it enrolls patients with metastatic castration-sensitive prostate cancer. And just like all the other trials, it allows for patients with any of these alterations. And key exclusion, as you can see, will be previous PARP inhibition or previous ARPI. So this is the randomization. Patients are randomized to abiraterone plus prednisone with ADT plus niraparib or placebo. And the primary endpoint will be radiographic progression-free survival. The patient population is quite typical of a high-risk population. Most of them have high Gleason score at diagnosis. Most of them have de novo metastatic disease at diagnosis with high volume disease. And of note, even though the study enrolled patients with any kind of HR deficiency gene per that panel, over half of patients consist of harbor BRCA1 or 2 alterations. So these are the results. It was reported as a positive study. In terms of primary endpoint, it was met. If you look here for the HRR mutant population, there's definitely an improvement. But most of the benefit seems to be driven. But if we look only at the BRCA mutated subset, the magnitude of the benefit was definitely much larger. So this was seen along with the secondary endpoint, time to symptomatic progression, although we did not see any overall survival improvement just yet. But this is just a first interim analysis and the data wasn't quite mature yet. So similar to what we have seen in the metastatic castration-resistant phase, when they looked at, when they performed subgroup analysis, most of the benefit really seemed to be driven by BRCA1 and 2 alterations, as you can see here highlighted in red. And in terms of toxicities, I did not put up side effects, but most of the toxicities will be quite within the range and the type of side effects that we have grown familiar with from a PARP inhibition across different tumor types. So the second abstract I'll be covering on would actually be an exploratory analysis of responders from a phase 3 trial, the phase 3 EV-302 trial of enfortumab vedotin plus pembrolizumab versus standard platinum-based chemotherapy in first-line setting for metastatic urothelial cancer. So once again, I believe many of you would have seen these survival curves. These results were first presented in ESMO, I think 2 years or so ago, and the results was reported in New England Journal of Medicine. And effectively at each subsequent ESMO, ASCO, GU, and ASCO, there's been some form of updates and sub-analysis. But basically, enfortumab vedotin is an antibody-drug conjugate targeting Nectin-4, and the payload being MMAE, which is a a microtubule inhibitor, quite similar to taxanes. And the control arm here will be either cisplatin plus gemcitabine or carboplatin plus gemcitabine based on standard cisplatin eligibility criteria that we use for bladder cancer. So we have seen this is a very positive trial. So this is a longer-term follow-up analysis. So the initial presentation at or the report in New England Journal of Medicine has 1.5 years of follow-up, and this has close to 3 years of long-term follow-up, and confirming the objective response rate of close to 70%, with 30 of which 30% represented complete response, which is quite remarkable even from most solid tumor perspective, and compared to 44% objective response rate in the standard arm of platinum-based chemotherapy. So among responders, you can see that those who received the experimental arm of enfortumab vedotin plus pembrolizumab, the duration of response is substantially longer than standard chemotherapy, although we can see definitely a drop-off of platinum-based chemotherapy here at around the six months mark. So for those who are vaguely familiar with bladder cancer treatment, you will know that we are quite obsessed with the concept of cisplatin eligibility. I mean, in a way, it is more of a reflection of host features rather than disease feature. So in this subgroup analysis, we did see that the combination of enfortumab vedotin plus pembro remains active regardless of cis eligibility status. And as mentioned, there's no difference in duration of EVP response regardless of cis eligibility status. But what's also interesting, even looking at the control arm, we can learn some stuff from there, especially since we don't have access to EV pembro right now, in the sense that the distinction between cisplatin treated and carboplatin treated groups remains apparent. And just as what we knew, the cisplatin-based combination is a much more potent combination than carboplatin combination. Although surprisingly, that we did see a long tail in the at least a cis-ineligible cohort, which presumably would have been treated predominantly with carboplatin, which we didn't see in previous studies. And then the presentation also looked at the fact that show that the depth of response may actually impact on duration of response. So here, two separate Kaplan-Meier curves, one on the right showing the duration of response among those who got a partial response, and on the left among those complete responders. And unsurprisingly, the complete responders have much more dramatic duration of response. In fact, you can see here for complete responders who receive EV plus pembro at 2 years, almost 75% of patients remain free from progression. Once again, from most solid tumor perspective, this is quite remarkable, I think. And similar pattern was seen among overall survival. So when you break it down, most of the benefits will be driven among those with complete response. So as you can see here, for those who receive EVP, 2 years, 95% of these patients remain alive. And these are all metastatic urothelial cancers with median overall survival back in the days of cisplatin and gemcitabine of around 14 to 16 months. So what we've seen, patients in general with complete response to either treatment arms have superior overall survival. Without question, this is exploratory in nature, but we definitely could see that the overall survival seems to be superior numerically among the EVP treated ones compared to platinum-based chemotherapy treated. And also important to remind ourselves that treatment with EV plus pembro leads to a complete response rate of 30%. So in a way, it may indirectly lead to more people with complete response and enable more people to have prolonged duration of response, better PFS, and better overall survival. So in fact, in some smaller group discussions and in some more specialized meetings, there are even commentators suggesting that we even start believe that inverted commas, a cure is potentially possible for a very small subset of these patients. And we always have the question of up until 2 years mark, do we stop treatment? Do we continue? That's going to be an ongoing question for this population. But then ultimately, there's always the cost, especially from a toxicity perspective. So this is definitely quite interesting to look at. So we'll look at the one top left here. The green represents the overall population and the blue represent the responders. And for responders, definitely unsurprisingly, they receive higher number of cycles, with a median of 12 to 13 cycles of EV among the responders. And the responders receive more cycles of pembrolizumab. So there is definitely a discordance between the number of cycles of EV and number of cycles of pembrolizumab which is suggesting that there is a subset of patients who may have stopped their EV along the way. And these two graphs on the right shows breakdown with side effects. Basically, what it shows is comparing, once again, in green bar, overall population, and in blue bar, responders. And they break down by different commonly expected side effects related to EV up here and Pembro down here. And among responders who have been on treatment much longer, they don't really have significantly higher degree of these side effects, which is quite fascinating, maybe other than slightly higher peripheral neuropathy among those responders. So I think this is actually the most interesting part, most practical part, that among the responders, there is actually a very much higher dose of dose reduction and dose interruption. And I'll provide a comment on this later on.
14 minutes, Min. You're at 14 minutes.
Oh gosh, okay. The next two is actually very fast. So, okay, abstract 4-5.
I need to keep it to 1 minute because we've got 3 more speakers.
Okay, so this long-term survival, 9 years follow-up. We've been using ipi/nivo metastatic clear cell RCC. So the key thing is to point that even after 9 years in intermediate and pro risk, we do see 30% of patients remain progression-free with ipi/nivo compared to sunitinib, and 30% still alive at 9 years. And lastly, belzutifan is a HIF-2 alpha inhibitor approved at least in the US for 3rd and 4th line setting for metastatic RCC, and at least in patient VHL disease-related tumors. And this is, a lot of the time they are surgically managed, but there can only be so much that the surgeon can operate it on. So this is quite remarkable. In this case, these are patients who have progressive disease, and for VHL-related RCC, overall response rate of 70%. For VHL-related CNS hemangioblasoma, response rate of 50%, and 90% for VHL-related pancreatic neuroendocrine tumor. So for these VHL-related tumors, this treatment can potentially be quite useful for them. Okay, so conclusion and take-home messages. So for the first Amplitude trial, it reflects a much more contemporary metastatic prostate cancer patient population. And for the subset of patients with BRCA1 and 2 alteration, it is definitely reasonable to consider them upfront in a metastatic castration-sensitive setting, although right now it's not approved in the setting. And from the exploratory analysis from EV302, it reaffirms the role of EV-Pembro as a superior first-line systemic therapy for metastatic UC regardless of platinum eligibility status. And what's more important, especially the last slide shows that maybe aggressive dose management and dose reduction and dose interruption at the correct time point is a key to optimize treatment exposure to get more long-term responders. And third, IO remains an excellent first-line treatment for metastatic RCC. And lastly, for the very small population of VHL disease-related associated tumors, surgery-sparing systemic therapy can be potentially useful, but this also must be balanced with the toxicity, which includes low oxygen saturation and anemia. That's where we are at.
Thank you very much.
Thank you.
Appreciate your acceleration at the end. Thank you.
No
so we've directed that any questions go into the chat, please, to our speakers in the interest of keeping on time. So the first of our final 3 speakers is Colm Eochagáin, who's going to do a head and neck cancer update. Welcome, Colm. Thank you for joining us today. We can see your slides.
Thank you, Seamus. Can you still see them?
We could see your slides.
Oh, apologies.
They're gone.
There we go.
Good, excellent.
Great. So thank you very much for the invitation to speak. It's been a very interesting year for head and neck cancer. There's been significant updates across nearly all of the major disease settings. But I'll focus in this talk on 3 key studies: perioperative and adjuvant immunotherapy in Keynote 689 and the Nivo post-op study for mucosal squamous cell carcinoma, and adjuvant immunotherapy for cutaneous SCC in the CPOST study. And if I have time, I may not. I'll talk through a rapid fire of 3 very interesting abstracts in 1 slide. I'll keep it quick. So the standard treatment for locally advanced resectable head and neck squamous cell carcinoma consists of either primary chemoradiotherapy or surgery followed by risk-adapted adjuvant therapy. So in the operative setting, low to intermediate risk patients typically receive radiotherapy, while high-risk patients, specifically those with extracapsular extension or involved margins, as defined in the ORTOG 9501, and EORTC 22931 studies receive adjuvant chemoradiotherapy with high-dose cisplatin. And although there have been some refinements to this paradigm, and particularly from JCOG 1008 and very recently from ORTOG 920, this approach has remained the standard of care since 2004 and served as the control arm for both the Nivo post-op and for Keynote 689. So although both nivolumab from Checkmate 141 and pembrolizumab from Keynote 48 are established in the metastatic setting, translating that efficacy to the curative setting has been very challenging. And there have been a litany of negative trials in this space, and particularly in the setting of definitive chemoradiotherapy. In contrast, these studies, Keynote 689 and Nivo post-op, were conducted in the perioperative and post-operative setting, which is an important distinction and may explain the difference in benefit that we are seeing with these studies. So first, Keynote 689 presented at ASCO, but also previewed at AACR about a month before ASCO, was a phase 3 open label trial involving 714 patients with stage 3 to 4A resectable squamous cell carcinoma of the head and neck. They were randomized 1-to-1, and the control arm underwent surgery followed by radiotherapy with or without cisplatin according to risk. And the investigational arm received 2 cycles of neoadjuvant pembrolizumab, then surgery, and then adjuvant radiotherapy or chemoradiotherapy with concomitant pembrolizumab, which was continued for 12 cycles. The primary endpoint was event-free survival. Secondary endpoints included major pathological response, overall survival, and safety. So patients were being considered for surgical management, so that resulted in a predominance of oral cavity primaries, approximately 60%. The remainder were primarily laryngeal, with fewer hypopharyngeal and oropharyngeal tumours. And there's still some debate, it should be noted, about whether surgery is always the preferred strategy for these oropharyngeal tumours. Generally in St. James's, our practice has been chemoradiotherapy for the majority, not all, but the majority of these patients. So 95% of patients had a PD-L1 CPS of 1 or above. Approximately 2/3 had a CPS of 10 or above, which is high relative to historical data. And there are some questions about progression through this study, which I'm afraid we don't have any real clarity on yet. And this is from the paper supplements. So in yellow, we see 10% of patients in the standard of care arm did not proceed to on-trial surgery versus about 1% in the intervention arm. It's not clear what the outcome for these patients was. And although you see in blue the receipt of surgery on trial was equivalent, about 89 versus 88%. In red, you'll see importantly that 15 patients, or about 4% of patients, came off study during the neoadjuvant pembrolizumab phase due to progressive disease, and that contrasts with 2% in the control arm. And I think looking at this consort diagram, there are questions here which I haven't seen clear answers to yet, either in the manuscript or in either the AACR or the ASCO presentation. Nevertheless, at a median follow-up of 38 months, event-free survival in all comers was longer in the investigational arm, hazard ratio 0.73 with a median EFS of 52 versus 30 months in the control arm. And this difference was primarily attributable to a reduction in distant failures shown here in red, and the other components of that composite endpoint being broadly similar between arms. So EFS, as expected, was greater in patients with a positive CPS shown here on the left, and enriched further in the CPS of 10 and above group shown here on the right. Again, this CPS of over 10 group was 2/3 of patients. So their median EFS was 60 months versus 27 months, which is very dramatic. And although we do see a gradual erosion of efficacy as the CPS as you add lower CPS patients into these interventions, the FDA approval, which has just recently been granted, has only granted approval for CPS patients, patients with CPS of 1 and above. And I think this is going to introduce some additional complexity into our workflows, because we will need this information in advance of treatment planning. So here's the forest plot. Hypopharyngeal cancer, clearly an outlier here, and there were small numbers in this group. It's not clear yet why these outcomes appear to be so different in this subsite. Toxicity was generally in line with what we understand for pembrolizumab, generally well tolerated, and most of the additional toxicity was related to thyroid endocrinopathy. So finally, this is from the publication. OS data is immature, but looks promising, particularly in the CPS enriched subgroup. Moving on to Nivo post-op, this was presented at the plenary session. It's a related study, very similar design. It's a GORTEC phase 3 study. So this time nivolumab rather than pembrolizumab and no neoadjuvant component. So this was an open label trial which randomized 680 patients with resected high-risk stage 3 to 4 head and neck squamous cell carcinoma to either surgery followed by 3 cycles of high-dose cisplatin chemoradiotherapy, or surgery followed by 1 cycle of nivolumab followed by chemoradiotherapy with concurrent nivolumab and 6 additional cycles of nivolumab once radiotherapy had ended. And the primary endpoint was event-free survival or disease-free survival. Key secondary endpoints were overall survival and safety. The distribution of baseline characteristics was well balanced. Similar to Keynote, the most common tumour site here was oral cavity, 58% in both arms, and most patients had a pathological stage 4A or 4B, with stage 4B alone accounting for about 50% of patients, so overall a higher risk population than the Keynote study. Importantly, these 4B patients would have been excluded from the Keynote study. 10% of patients were classified as high risk based on perineural invasion or 4 or more positive lymph nodes, which are features which by themselves would not typically warrant concomitant cisplatin. It represents treatment escalation in this standard of care group beyond routine practice, and it'll be very interesting to see what the breakdown of outcomes in this group is. About 90% of patients had a CPS score of 1 or more. So for the primary endpoint, 3-year disease-free survival was 63% with nivolumab versus 53% with standard care, hazard ratio 0.76. And unlike Keynote 689, the benefit here really was driven by improved local regional control as opposed to distant failure. The benefit was seen across subgroups, interestingly, without a clear correlation between CPS and outcome, which is unexpected. It's different from Keynote, but also different from how we understand nivolumab to work in the metastatic setting. So we know from Checkmate 141, although it's agnostically licensed with regard to CPS in Ireland, that study did enrich, CPS did enrich for benefit in that study. So it'll be interesting to see more granular data on this in the publication. As with Keynote, OS data is not mature. It has not been formally tested yet, but numerically and graphically, it does appear at this point to favour nivolumab. Again, tolerability was generally good. We don't have a granular breakdown of this yet. There was a slight increase in grade 4 toxicity, but no additional grade 5 toxicity. And finally, a brief note on the phase 3 CPOST study of adjuvant cemiplimab in high-risk cutaneous SCC. This is a commonly seen head and neck cancer. 80% of these patients in this trial at least, and probably closer to 60% in the real world, have a head and neck primary, although it is a cutaneous malignancy. Importantly, cemiplimab was reimbursed in Ireland in December for metastatic disease, and there's promising neoadjuvant data, phase 2 data, but very promising data from Neil Gross in the MD Anderson group, although this indication is not yet licensed in Ireland. And how these different indications will integrate into clinical practice really remains to be seen. So very briefly, this study randomized 415 high-risk patients to standard of care, which is surgery followed by postoperative radiotherapy, or standard of care, which is a radiotherapy plus adjuvant cemiplimab. So high-risk disease was defined based on criteria for nodal involvement, presence of perineural invasion, T4 lesions, patients with in-transit metastases, and patients with recurrent disease. Median age was 71. 83% of patients, as I said, had a head and neck primary. The primary endpoint was disease-free survival. Secondary endpoints included local, regional, and distant reoccurrence, overall survival, and safety. So for the primary endpoint of disease-free survival, there were 24 events in the cemiplimab arm compared with 65 in the placebo arm, with a hazard ratio of 0.31. Median DFS not reached in the investigational arm versus 50 months in the placebo arm, and 2-year landmark DFS of 87 versus 64%. And I won't show the forest plot here, but benefit was seen across all pre-specified subgroups. Again, in this study, OS is immature, but at the latest data cutoff had a hazard ratio of 0.78, not statistically significant. If we have time,
10 minutes there, Colm.
Okay, I'll leave this. Maybe I'll leave this slide up then. There's some interesting additional, these are phase 2 data, which really, I think, affirm things we're probably doing already. Maybe a special point for the BRAF anaplastic thyroid cancer, we have been able to get access to not exactly the regimen used in this study. This is an MD Anderson trial, but Roche have very kindly provided us with access to atezolizumab and BRAF MEK inhibition in this setting, and it's something to consider when you see these patients and are considering neoadjuvant treatment. The OR0 and OR1 resection rate in this study was 75%, and this is a doubling of the data seen in the ROAR trial, where pembrolizumab, in this study, pembrolizumab, our access is probably atezolizumab in Ireland based on compassionate use, but that's a doubling of what was seen in the ROAR study. So what will I do differently on Monday? There's some practice affirming studies, as shown in the last slide. There's a lot of change, I think, in the mucosal and cutaneous SCC setting. Very unclear, really, which of the two studies, NIVO post-op and Keynote 689, which are very similar in design, is likely to predominate, and how they will progress through regulatory and funding pathways remains to be seen. Thank you.
Thanks very much, Colm. Our next a very clear presentation. Our penultimate speaker is Professor Donal Brennan, who's the NCCP Director of Research and also consultant at the Mater Hospital and Professor of Gynecological Oncology at UCD. So this is one of two New England Journal of Medicine papers, which was published concurrently with a presentation at ASCO. So Donal, you're very welcome to join us, and we look forward to your presentation of the OASIS 4 trial.
Okay, so we'll crack through this, Katie. If you keep or Claire, sorry, if you keep going through the slides, that'd be great. The next slide, please. Just my disclosures. So yeah, this is just to kind of give you a background. So a number of years ago, a patient came to me and said, nobody's doing any work in cancer-related menopause in Ireland, and I had to hold my hands up and say, yes, that's true, and you can click on there, please. And we developed a menopause after cancer study that many of you also recruited to, which was run by Finn O'Donoghue. And this was one of the first studies to show a clinically significant impact in a multimodal intervention in, I suppose, menopause after cancer, particularly breast cancer patients. And the menopause after cancer study did give us a lot of leeway. If you click on there, it allowed us to I suppose, deliver what we thought was an improvement in both vasomotor symptoms and insomnia, but probably more importantly, it gave us an international setting. So we did publish a paper, you can click on there, Claire, in the management of menopause, both where we published a paper in the Lancet. Keep going, Claire, please. We've gone on to develop more studies in this area, and obviously now this led us to be able to recruit with Bayer to elinzanetant to the OASIS 4 study, which was published as Seamus said in the New England Journal. So elinzanetant is an interesting molecule. If you go to the next slide, please. It works, it's a non-hormonal molecule that works on the thermoregulatory system within the brain, within the middle of the brain, around the hypothalamus. And it's, for those of you that kind of remember your physiology, the hypothalamus pituitary ovarian axis is obviously a really important axis in the management of ovarian function, particularly in the premenopausal patient. But these candy neurons, as we call them, are neurons that secrete a number of different substances, and they regulate the thermal function within. They kind of keep your thermal, your internal thermometer at a certain level, but they're also right beside areas that actually control estrogen secretion, which is very interesting for future development. So next slide there, please. And you can click on through those to bring all those up. So the candy neurons have multiple areas that could be damaged or changed in women who have breast cancer. Tamoxifen can bind to them and alter their signaling. Obviously, if the patient's on a aromatase inhibitor, the reduction in estradiol will lead to hypertrophy or overactivity of the candy neurons. And then also, if the patient, you can go to the next slide, please. Once that happens, what you end up doing is getting activation, previous slide, please, of two different receptors, NK3 and NK1. And NK3 binds to Eochagáin B, which really causes the classic hot flushes and the vasodilation. But NK1, substance P binds to NK1, which is really felt to be an important player in sleep deprivation and insomnia. So if you think about the symptoms that patients get, as you all manage them, or as patients on the call will remember, hot flushes, night sweats, and insomnia are the major problem. And this is a medication that we believe can address those symptoms. Next slide, please. So this is just showing you in more detail how elinzanetant work. We call it a dual neurokinin targeted therapy. It inhibits both NK1 and NK3, so therefore it prevents substance P and neurokinin B, the two ligands binding to the receptors, as you can see there, in the brain, leading to hopefully a resolution of both hot flushes, night sweats, and insomnia. Next slide, please. There is another drug on the market called fezolinetant, just to say it's a single mononeurokinin targeted therapy that just binds to NK3. It's not licensed for the use in patients on current treatment for breast cancer, but it can be used potentially in patients who have completed treatment for breast cancer, and it is available. Next slide, please. So a number of trials were published last year in the non-cancer setting, and these are OASIS 1 and 2, and these did show in women who did not have cancer, who had significant vasomotor symptoms and who were not on HRT, that there was an improvement in both vasomotor frequency, in sleep, with an appropriate side effect profile, as you can see here. So in the non-cancer setting, elinzanetant has been assessed and is effective compared to placebo, but has not been compared to standard estrogen and based HRT. But the question, I guess, is, would it work in women who have breast cancer related symptoms? So if you go to the next slide, please. So we presented the OASIS 4 study at ASCO. This was an oral presentation at the plenary session, and then also it was published at the same time in the New England Journal, if you click on, please, Claire. And this was a really kind of important study, I think, because it's really it shows that this is an area that people are now becoming much more interested in. So if you go to the next slide. So the study itself, OASIS 4, was a very straightforward study. It was a randomization of patients 2-to-1, phase 3 randomization with patients with 2-to-1 with a history of breast cancer, or patients who are at high risk of developing hormone receptor breast cancer, and I'll explain that to you in a second, who are on estrogen, on anti-endocrine therapy. So the rationale at the time when the study was designed was that there was some places where tamoxifen was being used to prevent breast cancer, but in fact we only recruited one patient in that group. The rest of the patients all had ER positive, hormone receptor positive breast cancer on either tamoxifen or aromatase inhibitors. And the design was pretty straightforward. It was a 2-to-1 randomization to either elinzanetant, the investigational drug, or placebo for 12 weeks. It was double-blind randomized control trial. And then at 12 weeks, it was crossover, and patients were followed for up to 52 weeks and are now on an optional 2-year extension. And what I'm going to present today is really the 12-week efficacy data and the 52-week safety data. If you go to the next slide, please. So these were the key inclusion criteria. They're pretty straightforward, but really the women had to have quite significant vasomotor symptoms and were on either tamoxifen with or without GnRH analogues, or aromatase inhibitors with or without GnRH analogues, and having had filled out a hot flush diary for at least 11 days with at least 35 moderate to severe hot flushes per week, including nighttime episodes. If you go to the next slide, please. So the outcomes, you can click through all of those, please, Claire, where the primary outcome was the change in the average daily frequency of moderate to severe vasomotor symptoms from baseline to weeks 4 to 12 before the crossover happened. And this was an FDA-related outcome as well. This was important. We spent a lot of time working with the FDA to define these outcomes. And then the key secondary outcomes were change in the PROMIS score, which is a sleep score, and the change in the MENCOL, which is a menopause-based quality of life score. And then there were some additional secondary endpoints that you can see there. And obviously then we were going to report on standard treatment emergent adverse events. Next slide, please. So the demo, and you can click through all that, please, Claire. I suppose from a point of view of the demographics of this study, 88% of the patients were white. The mean age was well balanced at 50 across 50, between approximately 51 across both groups, with a relatively normal BMI across both groups. And as I said, almost all the patients were receiving anti-endocrine therapy for breast cancer rather than prevention. Next, if you click on there. And this is the primary endpoint. And you can see here a couple of interesting points. Here we can see the changes between weeks 4 and 12, with the darker bar being the investigational drug and the lighter blue bar being a placebo. And you can see that really from the average number of daily hot flushes in both groups was just over 11. And this reduced in week 1 to week 6, or to week 4 to week 12 quite significantly to 8, down, reducing from 11 to 3 really in the elinzanetant group. But there was also a significant reduction in the placebo group. And this is something we see quite frequently in menopause studies, both in the cancer and non-cancer setting. And it shows the importance of performing placebo-controlled trials in this group. But really, this did meet its endpoint. There was a significant reduction from baseline and obviously then compared to placebo. Next slide, please. And this just shows, I think, the changes compared to placebo of over 3.5 at both 4 and 12 weeks. If you look at that graphically and go to the next slide, please. What we felt was very clearly that we saw a very clinical and statistically significant reduction in symptoms at the 12-week period, as you can see here in the purple arm. And then when the patients crossed over between weeks 12 and 24, we saw a similar effect, and this was durable out to 52 weeks. And really, as you might have seen in my previous slide, what we saw was that more than 70% of patients had a 50% or greater reduction in their symptoms. And this is this is a way of kind of explaining how effective the drug is. If you go to the next slide, please. There was the same look at looking at the severity of symptoms, or the severity of vasomotor symptoms was similar. There was a significant reduction not only in the frequency but the severity. And in fact, a lot of the patients who had residual vasomotor symptoms had very minimal impact on their quality of life. Next slide, please. And then if we look at the secondary endpoints, the graph on the left is the sleep score, and the graph on the right is the quality of life score. And you can see that the baseline T-score was 60 in both groups at the top. That would suggest that most of these patients were suffering from significant clinical insomnia, as we'd shown previously in other studies. And we saw a significant reduction in the group who had elinzanetant compared to placebo. And this was reassuring because obviously the dual nature of elinzanetant, whereby it blocks substance P interaction as well, suggests that it would improve sleep compared to other drugs that we have available. And then likewise, we saw a clinically significant and statistically significant improvement in quality of life, as one would expect with resolution of these symptoms. Next slide, please. And that just shows you the same study, the same data based on time. And again, you can see when crossover happened that both particularly sleep improved, but also quality of life, as you can see there. Next slide, please. So with regards to safety, this is a safe drug from what we can gather. There are some concerns about fezolinetant, and the FDA approval, and that has now led to a black box warning around LFT or liver function. So patients who start fezolinetant need to have regular liver function tests at present, based on both FDA and EMA warnings. There was an independent liver safety monitoring board in this study, and we have not identified any liver enzyme alterations that were clinically significant in the study to date. But I would argue that in fezolinetant, that data only came to light post-trial. You can see here there were very few major significant side effects, but if you just click on that slide, please, I think there's something that's going to highlight. But you can see here that there was some issues around fatigue, somnolence, and diarrhea. We do advise patients to take this at night time. The fatigue story is interesting. You can see that 9.5% of the patients had complained of significant fatigue between weeks 1 and 12, but this didn't translate when they transferred over, as you can see further over in weeks 13 to 26 from the placebo group. So I think the fatigue story is something we're trying to work out, and the somnolence story likewise wasn't persistent later on. So these seem to be early onset side effects that may be mitigated over time. And the diarrhea was again something that we saw that we think with mitigation strategy might be easier to control. So overall, a very well tolerated drug. Next slide, please.
We're out of time, Donal, so just your summarization if possible. Thanks.
Yeah. So limitations there, the study are that it's mainly based on Caucasian white population. Next slide, or keep pushing through there, please, Claire. We don't have any data on patients who are at risk of developing breast cancer, but we don't really use anti-endocrine therapy in that setting here, to be honest. We don't have assessment of breast cancer outcomes, and we will continue to follow this cohort, but obviously it's not going to be large enough, I think, to do that, and that will require further data. And obviously there were exclusion of some patients with metastatic disease or patients with recent treatment who we need to understand what's going to happen going forward. And obviously we need to understand how this might work in patients, for example, on CDK4/6 inhibitors and other newer treatments for endocrine, newer treatments that we use in hormone receptor positive breast cancer. So to finalize, finish up there, last slide. So to conclude, this is the first neurokinin targeted therapy to demonstrate efficacy in patients on anti-endocrine therapy, and it did meet its primary endpoint. It demonstrated a rapid and sustained effect really from week 1, and I suppose it was very well tolerated. And I think the best endorsement of the study is that 99% of the patients who were offered to stay on the study after 52 weeks and the ongoing 2-year extension have decided to stay on it, suggesting that really this is a study that's changing their quality of life, which is really reassuring. And I think that's me done. Sorry about the slides issue.
No, thank you very, very, very much. Donal, I think especially after a hot week like last week, we would love and can't wait to get access to that drug for our patients. Apologies to everybody. We are running a little bit behind time. We have one speaker remaining. Don't worry, the MS Teams link is not going to expire. The meeting will continue for as long as we need it to. So we hope to be able to afford our final speaker, Professor Patrick Forde from Trinity, time to discuss his first author paper in the New England Journal of Medicine, which was also presented at ASCO. It's the follow-up final overall survival data from his Checkmate 816 study of chemotherapy with immunotherapy neoadjuvantly for the treatment of lung cancer. So welcome to Patrick.
Okay, so we can we'll crack through this, Katie. If you keep or Claire, sorry, if you keep going through the slides, that'd be great. The next slide, please. Just my disclosures. So yeah, this is just to kind of give you a background. So a number of years ago, a patient came to me and said, nobody's doing any work in cancer-related menopause in Ireland, and I had to hold my hands up and say, yes, that's true. And you can click on there, please. And we developed a menopause after cancer study that many of you also recruited to, which was run by Finn O'Donoghue. And this was one of the first studies to show a clinically significant impact in a multimodal intervention in, I suppose, menopause after cancer, particularly breast cancer patients. And the menopause after cancer study did give us a lot of leeway. If you click on there, it allowed us to I suppose, deliver what we thought was an improvement in both vasomotor symptoms and insomnia, but probably more importantly, it gave us an international setting. So we did publish a paper, you can click on there, Claire, in the management of menopause, both where we published a paper in the Lancet. Keep going, Claire, please. We've gone on to develop more studies in this area, and obviously now this led us to be able to recruit with Bayer to elinzanetant to the OASIS 4 study, which was published as Seamus said in the New England Journal. So elinzanetant is an interesting molecule. If you go to the next slide, please. It works, it's a non-hormonal molecule that works on the thermoregulatory system within the brain, within the middle of the brain, around the hypothalamus. And it's, for those of you that kind of remember your physiology, the hypothalamus pituitary ovarian axis is obviously a really important axis in the management of ovarian function, particularly in the premenopausal patient. But these candy neurons, as we call them, are neurons that secrete a number of different substances, and they regulate the thermal function within. They kind of keep your thermal, your internal thermometer at a certain level, but they're also right beside areas that actually control estrogen secretion, which is very interesting for future development. So next slide there, please. And you can click on through those to bring all those up. So the candy neurons have multiple areas that could be damaged or changed in women who have breast cancer. Tamoxifen can bind to them and alter their signaling. Obviously, if the patient's on a aromatase inhibitor, the reduction in estradiol will lead to hypertrophy or overactivity of the candy neurons. And then also, if the patient, you can go to the next slide, please. Once that happens, what you end up doing is getting activation, previous slide, please, of two different receptors, NK3 and NK1. And NK3 binds to neurokinin B, which really causes the classic hot flushes and the vasodilation. But NK1, substance P, binds to NK1, which is really felt to be an important player in sleep deprivation and insomnia. So if you think about the symptoms that patients get, as you all manage them, or as patients on the call will remember, hot flushes, night sweats, and insomnia are the major problem. And this is a medication that we believe can address those symptoms. Next slide, please. So this is just showing you in more detail how elinzanetant works. We call it a dual neurokinin targeted therapy. It inhibits both NK1 and NK3, so therefore it prevents substance P and neurokinin B, the two ligands binding to the receptors, as you can see there, in the brain, leading to hopefully a resolution of both hot flushes, night sweats, and insomnia. Next slide, please. There is another drug on the market called fezolinetant, just to say it's a single mononeurokinin targeted therapy that just binds to NK3. It's not licensed for the use in patients on current treatment for breast cancer, but it can be used potentially in patients who have completed treatment for breast cancer, and it is available. Next slide, please. So a number of trials were published last year in the non-cancer setting, and these are OASIS 1 and 2, and these did show in women who did not have cancer, who had significant vasomotor symptoms and who were not on HRT, that there was an improvement in both vasomotor frequency, in sleep, with an appropriate side effect profile, as you can see here. So in the non-cancer setting, elinzanetant has been assessed and is effective compared to placebo, but has not been compared to standard estrogen and based HRT. But the question, I guess, is, would it work in women who have breast cancer related symptoms? So if you go to the next slide, please. So we presented the OASIS 4 study at ASCO. This was an oral presentation at the plenary session. And then also it was published at the same time in the New England Journal, if you click on, please, Claire. And this was a really kind of important study, I think, because it's really, it shows that this is an area that people are now becoming much more interested in. So if you go to the next slide. So the study itself, OASIS 4, was a very straightforward study. It was a randomization of patients 2-to-1, phase 3 randomization with patients 2-to-1 with a history of breast cancer, or patients who are at high risk of developing hormone receptor breast cancer, and I'll explain that to you in a second, who were on estrogen, on anti-endocrine therapy. So the rationale at the time when the study was designed was that there was some places where tamoxifen was being used to prevent breast cancer, but in fact we only recruited one patient in that group. The rest of the patients all had ER positive, hormone receptor positive breast cancer on either tamoxifen or aromatase inhibitors. And the design was pretty straightforward. It was a 2-to-1 randomization to either elinzanetant, the investigational drug, or placebo for 12 weeks. It was double-blind randomized control trial. And then at 12 weeks, it was crossover, and patients were followed for up to 52 weeks and are now on an optional 2-year extension. And what I'm going to present today is really the 12-week efficacy data and the 52-week safety data. If you go to the next slide, please. So these were the key inclusion criteria. They're pretty straightforward, but really the women had to have quite significant vasomotor symptoms and were on either tamoxifen with or without GnRH analogues, or aromatase inhibitors with or without GnRH analogues, and having had filled out a hot flush diary for at least 11 days with at least 35 moderate to severe hot flushes per week, including nighttime episodes. If you go to the next slide, please. So the outcomes, you can click through all of those, please, Claire, where the primary outcome was the change in the average daily frequency of moderate to severe vasomotor symptoms from baseline to weeks 4 to 12 before the crossover happened. And this was an FDA-related outcome as well. This was important. We spent a lot of time working with the FDA to define these outcomes. And then the key secondary outcomes were change in the PROMIS score, which is a sleep score, and the change in the MENCOL, which is a menopause-based quality of life score. And then there were some additional secondary endpoints that you can see there. And obviously then we were going to report on standard treatment emergent adverse events. Next slide, please. So the demo, and you can click through all that, please, Claire. I suppose from a point of view of the demographics of this study, 88% of the patients were white. The mean age was well balanced at 50 across 50, between approximately 51 across both groups, with a relatively normal BMI across both groups. And as I said, almost all the patients were receiving anti-endocrine therapy for breast cancer rather than prevention. Next, if you click on there. And this is the primary endpoint. And you can see here a couple of interesting points. Here we can see the changes between weeks 4 and 12, with the darker bar being the investigational drug and the lighter blue bar being a placebo. And you can see that really from the average number of daily hot flushes in both groups was just over 11. And this reduced in week 1 to week 6, or to week 4 to week 12 quite significantly to 8, down, reducing from 11 to 3 really in the elinzanetant group. But there was also a significant reduction in the placebo group. And this is something we see quite frequently in menopause studies, both in the cancer and non-cancer setting. And it shows the importance of performing placebo-controlled trials in this group. But really, this did meet its endpoint. There was a significant reduction from baseline and obviously then compared to placebo. Next slide, please. And this just shows, I think, the changes compared to placebo of over 3.5 at both 4 and 12 weeks. If you look at that graphically and go to the next slide, please. What we felt was very clearly that we saw a very clinical and statistically significant reduction in symptoms at the 12-week period, as you can see here in the purple arm. And then when the patients crossed over between weeks 12 and 24, we saw a similar effect, and this was durable out to 52 weeks. And really, as you might have seen in my previous slide, what we saw was that more than 70% of patients had a 50% or greater reduction in their symptoms. And this is this is a way of kind of explaining how effective the drug is. If you go to the next slide, please. There was the same look at looking at the severity of symptoms, or the severity of vasomotor symptoms was similar. There was a significant reduction not only in the frequency but the severity. And in fact, a lot of the patients who had residual vasomotor symptoms had very minimal impact on their quality of life. Next slide, please. And then if we look at the secondary endpoints, the graph on the left is the sleep score, and the graph on the right is the quality of life score. And you can see that the baseline T-score was 60 in both groups at the top. That would suggest that most of these patients were suffering from significant clinical insomnia, as we'd shown previously in other studies. And we saw a significant reduction in the group who had elinzanetant compared to placebo. And this was reassuring because obviously the dual nature of elinzanetant, whereby it blocks substance P interaction as well, suggests that it would improve sleep compared to other drugs that we have available. And then likewise, we saw a clinically significant and statistically significant improvement in quality of life, as one would expect with resolution of these symptoms. Next slide, please. And that just shows you the same study, the same data based on time. And again, you can see when crossover happened that both particularly sleep improved, but also quality of life, as you can see there. Next slide, please. So with regards to safety, this is a safe drug from what we can gather. There are some concerns about fezolinetant, and the FDA approval, and that has now led to a black box warning around LFT or liver function. So patients who start fezolinetant need to have regular liver function tests at present, based on both FDA and EMA warnings. There was an independent liver safety monitoring board in this study, and we have not identified any liver enzyme alterations that were clinically significant in the study to date. But I would argue that in fezolinetant, that data only came to light post-trial. You can see here there were very few major significant side effects, but if you just click on that slide, please, I think there's something that's going to highlight. But you can see here that there was some issues around fatigue, somnolence, and diarrhea. We do advise patients to take this at nighttime. The fatigue story is interesting. You can see that 9.5% of the patients had complained of significant fatigue between weeks 1 and 12, but this didn't translate when they transferred over, as you can see further over in weeks 13 to 26 from the placebo group. So I think the fatigue story is something we're trying to work out, and the somnolence story likewise wasn't persistent later on. So these seem to be early onset side effects that may be mitigated over time. And the diarrhea was again something that we saw that we think with mitigation strategy might be easier to control. So overall, a very well tolerated drug. Next slide, please.
We're out of time, Donal, so just your summation if possible. Thanks.
Yeah. So limitations there, the study are that it's mainly based on Caucasian white population. Next slide, or keep pushing through there, please, Claire. We don't have any data on patients who are at risk of developing breast cancer, but we don't really use anti-endocrine therapy in that setting here, to be honest. We don't have assessment of breast cancer outcomes, and we will continue to follow this cohort, but obviously it's not going to be large enough, I think, to do that, and that will require further data. And obviously there were exclusion of some patients with metastatic disease or patients with recent treatment who we need to understand what's going to happen going forward. And obviously we need to understand how this might work in patients, for example, on CDK4/6 inhibitors and other newer treatments for newer treatments that we use in hormone receptor positive breast cancer. So to finish up there, last slide. So to conclude, this is the first Eochagáin targeted therapy to demonstrate efficacy in patients on anti-endocrine therapy, and it did meet its primary endpoint. It demonstrated a rapid and sustained effect really from week 1, and I suppose it was very well tolerated. And I think the best endorsement of the study is that 99% of the patients who were offered to stay on the study after 52 weeks and the ongoing 2-year extension have decided to stay on it, suggesting that really this is a study that's changing their quality of life, which is really reassuring. And I think that's me done. Sorry about the slides issue.
No, Thank you very, very, very much. Donal, I think especially after a hot week like last week, we would love and can't wait to get access to that drug for our patients. Apologies to everybody, we are running a little bit behind time. We have one speaker remaining. Don't worry, the MS Teams link is not going to expire. The meeting will continue for as long as we need it to. So we hope to be able to afford our final speaker, Professor Patrick Forde from Trinity, time to discuss his first author paper in the New England Journal of Medicine, which was also presented at ASCO. It's the follow-up final overall survival data from his Checkmate 816 study of chemotherapy with immunotherapy neoadjuvantly for the treatment of lung cancer. So welcome to Patrick.
Perfect. Okay, well, I'll try and run through this pretty quickly. To give a little bit of background to the study, so we presented this in the lung cancer sessions at ASCO this year, and the background is that historically for non-small cell lung cancer, the standard therapy for most patients with stage 1, 2, and 3 disease has been surgical resection followed by adjuvant chemotherapy, particularly for stage 2 and 3. In recent years with immune checkpoint inhibitors, there has been a lot of study across tumor types, particularly in melanoma, suggesting that neoadjuvant or preoperative, so giving the immune checkpoint inhibitor before surgery might be more effective. And we did a trial about 10 years ago now looking at single agent nivolumab anti-PD-1 prior to surgery, which suggested it might be effective. And then about 3 or 4 years ago, we presented initial results from Checkmate 816, which was the phase 3 trial, which I presented at ASCO. So the way ASCO gets us to present these things is essentially you give the results up front, so it's apparently educationally more beneficial. So in this study, this was a final analysis from Checkmate 816. Neoadjuvant nivolumab plus chemotherapy showed a statistically significant and clinically meaningful survival benefit against chemo alone. So this was 3 cycles of nivolumab added to chemotherapy. And it also showed benefits specifically in terms of lung cancer. So the median age of patients in this trial was about 68. So they do have some competing risks in terms of other conditions like COPD and other medical conditions which can affect mortality. And also seen in the study was a long-term event-free survival benefit. And when you're talking about neoadjuvant trials, essentially event-free survival is similar to progression-free survival in advanced lung cancer. It's a short-term surrogate endpoint. Those patients who had a pathological complete response to neoadjuvant therapy in the trial had improved long-term overall survival. And those patients who cleared circulating tumor DNA during the neoadjuvant treatment also had improved overall survival. So again, some of the background, we initially presented results from this phase 3 trial about 3 years ago now. This showed that giving 3 doses of nivolumab with neoadjuvant chemo improved event-free survival and pathological complete response compared to chemo alone for patients with stage 2 and 3 lung cancer. And you'll see the numbers there. The PCR rates were fairly dramatically improved. At the moment, this is the only approved neoadjuvant only chemoimmunotherapy regimen. In Europe, it's approved for patients with PD-L1 positive disease, so 1% or above. And this was the final overall survival results. Here was the design of the trial. So a few things to note. In the current 9th edition of staging for non-small cell lung cancer, this would be stage 2 and 3 disease. Patients with known EGFR or ALK alterations were excluded. They were randomized to 3 cycles of neoadjuvant chemotherapy or 3 cycles of chemo plus nivolumab. Surgery was planned within 6 weeks of the last dose of treatment. And then in the post-operative phase, there was no mandated treatment. So the oncologist and the patient would make the decision as to whether further treatment was required. And the primary endpoints were PCR and event-free survival, but overall survival was a secondary endpoint, which had statistical power and would be evaluated if the first 2 endpoints were positive. And this was that statistical analysis plan. Again, PCR and EFS were tested initially. If these were both as significant, then overall survival would be tested hierarchically with the 2-sided type 1 error of 5%. The overall survival analysis would occur at 185 events or 5 years follow-up. We actually didn't have 185 events, so this was the final analysis at 5 years. And this was showed a statistically significant improvement in overall survival with the addition of 3 doses of nivolumab to chemotherapy, showing a p-value of 0.0479, a hazard ratio favoring nivolumab plus chemotherapy of 0.72, and an absolute benefit at 5 years of 10%, 65% versus 55% with chemo alone favoring nivolumab plus chemo. So one question which arises when you give a therapy for earlier stage cancer, would the outcomes be just the same if the patients got the treatment later? Now, so in this setting, so if you look at the right of the screen, those patients who had disease progression or recurrence, more patients in the chemo alone arm received subsequent immunotherapy, so 51% versus 25% with nivo plus chemo. But this didn't appear to abrogate the early benefit from nivo plus chemo in the neoadjuvant setting. When we look at various clinical subgroups in terms of benefit from nivolumab plus chemotherapy, it appears to be present across the different subgroups. For example, stage, there's relatively similar benefit from stage 1B and 2 disease versus stage 3. We also see benefit across PD-L1 strata, however, more benefit for PD-L1 positive disease. And here we see the Kaplan-Meier curves. So if you see a patient in clinic, for example, with stage 2 disease in the 9th edition, you can probably say to them, if you receive neoadjuvant nivolumab plus chemo, you'll have about a 5% absolute survival benefit at 5 years versus chemo alone. With stage 3A disease, which is more locally advanced, the benefit is more, probably 12% absolute benefit at 5 years from the addition of nivolumab to chemotherapy. Here we see the PD-L1 results, and keeping in mind that in Ireland and the European Union, the approval for this regimen is for PD-L1 positive. So you'll see on the right of the screen about a 20% improvement in overall survival at 5 years for those patients who receive neoadjuvant nivolumab compared to chemotherapy alone. In the PD-L1 negative group, the hazard ratio perhaps trends in favor of nivo plus chemo, but a very minimal absolute, if no improvement at 5 years. Looking at lung cancer specific survival, so here the numbers are shifted essentially by 10% because you exclude all the non-lung cancer causes of death. About 75% of patients are alive at 5 years with nivo plus chemo versus 65% with chemo alone. Now, event-free survival is interesting in this case because one of the questions which arises is which patients may have relapse of disease after surgery. And here we see a continued benefit at 5 years, but almost half of the patients in the nivo plus chemo arm have an event, which could be disease progression or death related to cancer. One of the advantages of giving neoadjuvant therapy is that you have this pathological complete response readout, which occurs within about 9 weeks of the first dose of treatment. And here we see that those patients who have a pathological complete response, which is no residual viable cancer at the time of surgery when the tumor is removed, have a very good outcome. More than 95% of those patients are alive at 5 years, compared to 56% of those patients who don't have a pathological complete response. So you could imagine that for those patients who don't have a PCR, you might think of intensifying therapy in terms of clinical trials. However, among those patients who had a PCR, death had occurred at 5 years in 3 patients, and none of these deaths were due to disease. Again, looking at event-free survival, so quite a lot of benefit. If you had a PCR, it was 88% at 5 years versus only 35% if you did not have a PCR. And among those patients who had a PCR, 3 patients had a recurrence of disease or relapse. However, one of those patients had an ALK-positive tumor, which you wouldn't expect to respond very well to immunotherapy. And the other 2 patients, their treating oncologist had decided not to give them further systemic therapy, and they had done well. So the supposition there is that perhaps they had blinded independent review suggesting recurrence, but it wasn't an actual clinical recurrence in the clinic. Briefly looking at ctDNA clearance, so those patients who cleared ctDNA during the preoperative phase did better. They had a 75% 5-year overall survival versus 53% in those patients who didn't clear ctDNA. I think this isn't ready for clinical uses yet, but it is provocative in terms of future studies. And one of the key advantages of this treatment is you don't really add much in terms of toxicity. So the toxicity rates across chemo alone versus chemo plus nivolumab are very, very similar. So in summary, the 5-year analysis shows an approximate 10% improvement in survival for those patients who get Nivo plus chemo. There's also an improvement, a similar improvement in lung cancer specific survival. If you have a PCR or no residual viable cancer at the time of surgery, you have a 90% reduction in the risk of death, and you're likely to do very well. You probably don't require further therapy versus those patients who don't have a PCR where therapy could be intensified. ctDNA clearance was improved, was associated with long-term overall survival improvement, and the safety profile was similar between the two arms. So thanks very much. And again, my apologies for my delay joining.
Well, in fairness, when it's with a trial like that and a publication like that, you're allowed. We give you a bit of liberties. Thank you, Patrick, and for dialing in on your holiday.
Yes.
Great talk.
Patrick, can I ask you one question? Is there a role for adjuvant immunotherapy? Should we be ignoring adjuvant post-op immunotherapy in favor of neoadjuvant therapy? Emily Harrold had a very similar view, well, not as strong, not as emphatic, but there was also similar signals in patients with mismatch repair testing, mismatch repair deficient. So do you feel that the adjuvant immuno checkpoint inhibitor therapy adds anything to these patients?
Yeah, I think, Seamus, it's so the vast majority of the benefit seems to be in the neoadjuvant setting. You may have some additional benefit for higher risk patients. So for example, patients historically where we would use adjuvant chemotherapy, they were the higher your risk, the more benefit there might be. I think we see something similar. So PD-L1 negative lung cancers, for example, those patients who don't have a PCR, ironically. So if you don't have a PCR from neoadjuvant therapy, you might derive some benefit from an extended course. But it appears the vast majority of benefit is from the neoadjuvant phase. And if you look at the cost effectiveness analysis there, so essentially comparing neoadjuvant only versus perioperative, it's about 3 to 4 times more cost effective to give neoadjuvant only versus a full year of perioperative therapy. So it's one situation where I wouldn't necessarily be advocating for longer courses of therapy. I think there is also the risk for patients who could well be cured of giving a long course of therapy, where serious adverse events are rare with immunotherapy, but they can be really severe if they occur, you know. And I think the other thing would be in terms of clinical trials, if you don't have a PCR, I think that's a setting where there's a lot of avenues to intensify. For example, you could look at a KRAS inhibitor where there's some good drugs coming along, which might be effective for patients in those scenarios.
Okay. Thank you very much. An excellent presentation, and it's wonderful to end this meeting with two fantastic exemplars of clinical researchers from Ireland, what they can achieve. It's inspirational for many of us on the call. So I'd like to finish by thanking everyone for joining us this evening, and for our administrative help, Claire and Angela and her team at Cancer Trials Ireland. We're very grateful, and it's part of an effort of Cancer Trials Ireland to get young investigators and the oncology community aware of what's happening and involved, and also demonstrating ways in which we can help advance cancer care in our communities. So I wish you all a great evening, and to join Professor Higgins in the sewing bee. And for those who aren't, I wish for everybody, I wish you all a great summer. And thanks very much for joining us this evening. And we're delighted to see our patient partners on the call as well, and we welcome their insights in future meetings here and elsewhere. So thanks everybody, and thank you for joining us this evening on behalf of Cancer Trials Ireland and ISMO.